Good afternoon, everybody. It is definitely a small, packed house, so that's good. Real quick, for those of you on the live stream, we're going to go into working session. We're going to do it here as part of the working session so you all can participate. We'll do the best we can to keep the mics open, so the cross banter you'll be able to pick up, but there might be some, especially for the folks here in the front, where they won't be able to turn around and speak into the mic. So we'll do everything we can to either repeat or give some clarity in terms of where we're at. So I hope that works. I'd like to welcome everybody. This is Representative Tarvin just said to me, and I appreciate the comment, Representative Tarvin. This is an important subject that requires a lot of brain damage. So that's exactly what we're going to do for a couple hours right now, is do a little bit of brain damage and actually get to work. The preference was to be able to get around a table, frankly. So for those of you who've moved to the front, I appreciate that. But for the purposes of live stream and open and transparent government, we want to go ahead and keep this inside of the conference room. Before we get going, if we could, just for the record, and I hate to ask you guys to turn around and talk into your mics, but can we just say who is here and just for the record? So we'll start with Representative Tarvin. We'll open your mic up, and if you could just do that.
I'm Representative Tarvin, and I'm here.
Thank you.
Representative Darlene Taylor, District 173.
Representative Gerald Green, District 151.
Dane Peterson, Emory Healthcare.
Teresa Finch, Doctors Hospital of Gus.
Vince Wiegand, Legislative Counsel's Office.
Spencer Fry, represent House District 118, and
all right, thank you. The agenda, if you guys got that, was just a review of the last meeting, a review of the PowerPoint that you all should have. If those of you in the audience need the PowerPoint, let us know. Bring up your email to us, and we'll just email it out to you if you want to follow. In terms of the model, we've gone ahead and we've put a model together. Please do not expect MIT level type sophistication. It's meant to be a proxy, but I do think it starts to give us an understanding about what occurs. Review of the bill. Everyone breathe. We won't be doing a wordsmith session, but council was kind enough to be able to start a framework of the bill. And in my mind, a framework's important because it's hard to react to something unless you see something. So let's just go ahead and we'll take a look at that and then get into next steps. But ultimately, I think Representative Tarvin, you said it again, so my apologies for quoting you twice. But I don't think we can really get down to the bottom of this until we work through every issue. And the question really becomes is what's happening today and what's happening tomorrow. Some of the things to be thinking about as we go through the next 3 hours, first is where we set the floor. And you probably saw an article in the AJC on Sunday. I was using gross revenue. I'm not necessarily a believer that gross revenue is the right number. By the fact, I'd argue it's not the right number. But right now, for proxy purposes, that's what we used. But what is the floor that we want to set? What is the definition of indigent and charitable care? We are not bound by, guess what? The federal government. We're not bound by state government. So if we want to define it as 100% of FPL, if we want to define it as 138, 200, 300%, I mean, it really comes down to the committee's decision to define how we want to handle that definition of who are those folks within that strata that we want to be able to do this type of work for. Third, who's covered? Is it just the nonprofits? Is it nonprofit and profit? Is it ASCs or surgical centers and the hospitals? I mean, again, I'm not trying to lead the witness here. I'm just trying to give you guys kind of some food for thought. Next is, what is the allocation? And so let me just give a very simple example. If we all agreed that the floor, and just using gross revenue as a proxy, not because I believe it to be the case, but if the floor amount of indigent care we want to do is $1 billion, okay, then do we want to allot 1 billion credits so that each credit's worth $1 coming out of the gate? Do we want to allot 1 million credits? Then each credit's worth what, $1,000? Again, that's a question that we'll be looking at. And then last but not least, penalties. And I hate to use the word penalties. If someone has a better phrase, let me know. One of the questions One of the questions that was proffered by one of the committee members was, well, Todd, why wouldn't I just buy the credits and not do the indigent care? And I said, because there's going to be something on top of the credits if you do not get below the floor, pardon me, above the floor. So there is not going to be an opportunity for you, not you, pardon me, but euphemistically you, to basically say, you know what, I can just pay, and I'm just going to say a random number here, $100,000 and I'm out. No, it would be any unit below the floor that you are. It's the cost of abatement, so that would be the unit cost, plus some premium that would discourage you from effectively buying your way out of what society is saying is the right thing to do. So that means you have the incentive to innovate. You have the incentive to create relationships with your fellow hospitals, maybe that are ASCs or whatever we decide. In other words, you now have a higher incentive to work together and be, quote, part of the ecosystem that provides this very, very, very important level of care. I'll stop right there, and before we jump in, I wanted to give anybody an opportunity to make a statement or ask a question. Representative Fry.
Thank you, Mr. Chair. Appreciate y'all being out here today. I just wanted to reflect on that article on Sunday and let you know it's the first time I ever spoke to a reporter outside of Athens, Georgia, that I didn't drink beer with and hang out with on the weekends. And I told him as much. And I just wanted to be on the record that I would never disparage anybody's plan for such an innovative idea, and did not use the words that were attributed to me. The chair and I have discussed this over the phone. I discussed this with the reporter, who I hope you're watching, because you should have quoted me right. And what I was trying to explain was in the context of whether we should expand Medicaid or not, that I feel like that is the best way for us to get dollars to the rural hospitals. But what was printed in the AJC was that I said this was a poor choice. And it's not a poor choice. It's one of the most innovative ideas that I've seen since I've been in the legislature for about 7 years now. And I appreciate the chair for understanding that. And I would never do anything to disrespect Chairman Jones, except for wear this sweater to his committee meeting and sit right next to him. Thank you.
Your mic is turned off the rest of the session. Okay. No, Dane, please. Or Mr. Peterson. Yeah.
Great, thank you. Hey, the only one I would add to the 5 points, if the team thinks so, is how wherever we land impacts other parts of the framework of like DCH's 3% charity responsibility through CON, Care Trust Fund, the Medicaid expansion, all those other things. As we were looking through this over the past few days, is a lot of there's lots of questions as we work through this, but how it interacts and interplays with the rest of what I would call the state infrastructure or framework will be interesting to see how we work through that.
So we want to try and look around corners and
No.
not have any unforeseen circumstances.
Yeah,
right.
it's just
exactly
what happens.
Yeah, the
to
unintended
this.
consequences.
Yeah.
Okay,
Great,
got
thank
it.
you.
Yep. Okay.
Yeah.
No, thank you, Dane. Anybody else that want to add to the list? Yes, Representative Taylor.
Thank you. Mine is going back to the first part of your statement, and it had to do with the definition, and that we have the ability to set things wherever we want, whatever the rating is. I'm trying to picture how this works. My mind is a payer, and this is totally different. So I want to make sure that if somebody uses a clinic that's a certain, like a FQHC, if you make a deal with an FQHC, which some of these clinics are, I mean, there's a difference between a charity one, is it going to affect them for the rest of their patients, or how they're reimbursed for other things like Medicare and Medicaid? I want to make sure we're not having unintended consequences where we're hurting them in another way. And that jumped out at me, very much so. So I can't ask them to jeopardize something else, and they are just monumental in my district, so I can't jeopardize that.
So first, absolutely.
That
So-
is really, and when you say the we, who's going to be using it? The big we, everybody, the folks, whoever they are. I've been to the FQHC, but whoever it is that goes, when we talk about the person, the patient, let's just call him the patient, and they're using that service, we're going to set who would qualify as a patient or who as a facility, or do they have to be jointly
So-
defined? Does that make sense?
Oh, that makes complete sense, and I
So-
think we have this challenge, Representative Taylor. It's, first, which facilities do we want to say are under floor and trade? And again, maybe it's just nonprofit hospitals. And again, I'm not making that decision
Yeah.
for the committee, but let's just say, so that's number one. So then, the HCs are out then, because
Yeah.
they're not a nonprofit
Right.
hospital.
It would be,
Right, so this wouldn't even affect them, assuming we didn't include them. Secondly, to your point, that patient,
who, can I go? Can my neighbor go, or can the
You-
kids across the street?
everyone can still go, and if you have insurance, you'll have insurance, you have Medicaid, you have Medicaid, Medicare, so we're not even going to touch any of that. All we're saying is for the purposes of this program only, maybe we want to keep the definition of indigent the exact same as the federal definition, so there's no confusion. Or, and again, I'm not trying to lead the witness here, or maybe here in Georgia, we want to take certain leadership, if we consider it leadership, and say, you know what? True indigent really is at 200% of the federal poverty level. So whether or not the feds call 138, 100, whatever it may be, we believe this system should cover. So then that way we're going to ask whoever we're asking to be covered, again, and we'll just call them the nonprofits for right now, hey, does that seem fair to put that burden onto the nonprofits to be able to handle indigent care up to 200? Now, some of those are all going to have Medicaid, some will have Medicare.
Well, that was my
So,
next
again,
question. Are
that
they-
doesn't affect any of that type of payment
Okay.
into, and again, I'm going to use Dane and Emory just because he's sitting right to my left, but that doesn't affect any money moving into Emory on how they'll be reimbursed from Medicaid or Medicare
Would they-
or private insurance.
Would they be reimbursed the same way? I guess.
Absolutely. Yeah, we're not even trying
We're
to
not
touch.
touching that. Okay.
Absolutely not.
If the person comes in and they have Medicaid and they go there, they're treated, nothing's any different for them.
No,
Now,
if they have an
bring their adult
appendicitis-
child in that just doesn't have insurance, doesn't have a job, but doesn't qualify for Medicaid because they're over age, they're not a kid anymore, and they go there. That is the group you're talking about. This would be a 20-year-old that has no insurance, doesn't have a job. Is that who you're talking about? They would then go to Emory and they would be in that classification?
Yeah, because they would typically, let's just say they live right there.
They live with mom, they don't have any money,
Exactly,
they
and
don't
they're in
have
the
a job.
Emory area, and they go
Okay.
to Emory, and I'm using the one here near downtown, not Johns Creek, for instance, but they go over there, they're still going to get the exact, that child, or pardon me, that adult child will still be treated the way the Hippocratic Oath and all the policies of Emory
Okay.
require.
And Emory would then be reimbursed or paid, or how, what are you going to
No,
do
this
with
is a
that
great question.
encounter? That's what I
So
want
what
to
we're
know.
going to do is, and again, I'm making this very simplistic. Let's call that person Bob Smith. So Bob Smith goes in, and he is defined within how we've defined indigent. And let's assume for a moment it's 138 of federal poverty. Okay, they're going to go ahead, assuming what we agree to here. Again, I'm making a bunch of assumptions
Yeah,
here.
this is assuming.
We assume that we're going to go with DRG codes for inpatient hospitalization as our unit. Again, that's just inpatient, but let's just go with that for a second. Hypothetically, it's $10,000 of value that Emory has given to Bob Smith. So now there's going to be basically into, I hate to call it the plus column, but into the column that Emory is going to be able to report, $10,000 Bob Smith appendicitis. And again, I don't know the
Well,
DRG codes.
okay.
So now when they're looking at the floor and say Emory's floor is $1 million, which is going to be probably more than that, but $1 million, Dane is able to go with his CFO and go, that's $10,000 against $1 million floor, because he's not getting compensated for that because you said they don't have Medicaid, Medicare,
Right.
private insurance, or anything like that.
For example, every hospital facility has their own billing codes. So you can
Right.
have an appendectomy done at one facility at one price, and if you've got one, you got one, and that's all you've got. You cannot, unless you use some type of federal DRG or program when they do the billing. I don't know if you're going to use a Medicaid. Sorry, that's my.
You're right, you're talking about a standardized billing
Yes,
system
that's right. There
across
is no
all these
standardized.
That is correct. So the
what I'm
normalization, which is what we're calling that, right? The normalization, again, now I'm going to pick on Teresa too. So between doctors and Emory, we're going to have some standardization so that those codes for Bob Smith within those two, they have more than one campus. But the point being is, it's $10,000 and $10,000, not $20,000 and $10,000.
Regardless of the payer, we still can determine which DRG that patient episode fits in. It doesn't matter if it's
Right.
self-pay, charity, Champus,
You know the
Medicare,
cost of
Medicaid.
it.
We know what DRG that patient is coded into.
And everybody would use the same DRG, whether you're at Archibald or whether you're at Emory. or-
That's what Medicare does now. It's what Medicaid does here in the state of Georgia.
And everybody gets reimbursed the same exact amount
And
based
in the
on
state
that.
of Georgia, we all get reimbursed the same for Medicaid, and then Medicare federally, we get reimbursed the same for that DRG.
Okay.
Does that make sense? But you bring up great questions, because to your point, that was why when you looked at the white paper, and again, I'll give the guys at Kellogg credit, they were the ones that turned me on to the DRG, and I'm not married to it. It's just something that I keep thinking about, is at least there's a standard unit, Representative Taylor, of, okay, appendicitis is this, and I know the DRG has a lot of things on appendicitis, but the point being is it's one common unit that already the two biggest providers of medical care are using, Medicare and
And
Medicaid.
many of the commercial payers are also using
Oh, they
the
are?
DRG
Okay.
payment
Well, we
as
use
well.
that in some, but not in all contracts. What and how does this affect our dish payments? That was my next question. Right now, we have dish distribution for the rural hospitals and those with a high percentage of indigent care. How is this program going to affect the dish program?
Again, by the way, I shouldn't only be the only spokesperson as a working session, but my view of it after speaking with people is I'm not looking, this committee and this idea was never around the idea of affecting dish payments necessarily. Because we're not looking to disqualify anyone or qualify anyone into that. We're just saying this is what we need to achieve. Now, that stated, I think the two of them are first cousins. They're not second cousins. I think there's an argument to be made to Dane's point around the implications to the framework. So pardon me for not quoting you correctly, but the implications to the framework, I think we need to determine when you think of dish and you think of this, because they're first cousins, is there some implications to it, either positive or negative, that we need to take into account? And should there be a calculation against what you're getting with dish that could possibly affect
Correct.
your achievement of the floor?
That's where my point was
Oh,
going
okay,
with that.
okay.
Because there
Yeah.
will be an effect.
Yeah,
and
oh, no, there's no doubt.
Some
Yeah.
of the little rural hospitals are going to keep that same amount of indigent care they've always had, and how are they going to be compensated, or their dish won't be affected? By the same token, Emory will probably have more traffic, so you're going to have more opportunities to have indigent patients. I don't know if your percentages would change. And how does that trickle down? Are you
Right.
going to have it where? To the rural hospitals and that type of issue. I want to look out for the rural guys. How are they going to be compensated
And-
when they're not going to have?
I think we need to, and it might be, unless someone feels as if they can act as an expert, I think we should ask someone to give us the actual implications. In my mind, I saw it as a first cousin, and I saw it as if it could be something that we use as the calculation against the floor possibly. But we don't want to, Representative Green, we definitely do not want to cut off anyone or choke anyone. This is meant to create innovation. This is meant to create, hey, what happens if we did this? We could really find a way, and maybe there's a partnership that occurs between, I'll just say, a better hospital with a better balance sheet in certain parts of the state versus a hospital with a poorer balance sheet. Is there a way that maybe that hospital with a better balance sheet says, you know what, there's a partnership between us to be had here that would collectively allow each of us to do better with the floor? You know what I mean? And maybe there's an infusion of cash that occurs by cost of this system, but we definitely don't want to choke anyone off of payments.
Well, that happened, Mr. Chairman, with when we created the 100% if you donate to the hospital. Well, they changed the rules on us, so our rural hospitals ended up this year at a lesser rate, and it has really excited a lot of those.
So are you saying that because of the tax credit that we allowed to go to rural hospitals, that it affected their dish payment amounts
Yes.
overall?
Yes.
So they basically used the rural hospital funding
They have a
to,
cutoff at certain, and then the only thing that you ended up with was what your local people donated.
okay, now that's something that I think this committee is in charge to do, but that is a great thing that we need to be talking about, because that's what we wanted to help solve some of the problem is not even solving the problem. It's almost like this is how much you get and that's it.
They did go down for other hospitals besides his this year.
Okay. So let's keep that in the, I want to call it the Dane bucket right now, which are the unintended consequences bucket, which I think, by the way, I say that as a compliment, not as anything derogatory, but I think we need to keep this in mind because things like that. The last thing we want to do with this process is it was really meant to cause innovative thinking around taking care of that strata of our population that frankly needs it. The last thing we want to do as an unintended consequence, and frankly, what is it, cut off your nose to spite your face? It wasn't intended that way. So let's think around as many corners as we can.
Will it include inpatient? Will it include in and outpatient clinics? We now, for example, in Atlanta, are seeing some standalone ERs. Is it going to affect all types of providers, or is it just inpatient hospital?
That's our decision. So
Okay.
one of the decisions we need to make of those 5 items is, to me, who's covered? Like, is it, and again, I'm not picking on nonprofits, is it just nonprofits, profits, is it ASCs, is it urgent cares, is it, I can keep going with all the acronyms, but I think you guys get my point.
Yeah.
Who should be covered in this? Meaning, when I say covered, meaning who are we going to say, we believe the obligation of charitable care and indigent care is so important that your organization, whatever your organization is going to be included in this process. And there's pluses and minuses to, quote, including a lot versus including fewer, okay? And I'm sure several of the stakeholders will have an argument to be made on whether or not they should be included or not.
Okay.
Teresa, do you?
No, I think we covered in 3, who's covered.
Yeah.
And how are we thinking about the for-profit hospitals, ones that are paying a lot of taxes in this state right now?
And again,
Would
to
they be on
me,
the same level playing field? How would we do that?
I think that's the first argument to not have them in the system, in my opinion. The first argument is, hey, they're already paying, they're not getting the tax breaks that the nonprofits are getting. They're already, in a sense, giving to their communal benefit. So we're going to just leave them outside of this system. I definitely believe that that's an argument. I think the counter to that will be, should we take a look at, not because I'm trying to probe anyone or anything, and just get a better understanding for the committee's purposes. Hey, everyone, the effective tax rate they're paying is, and I don't know it, so this is just, for those on the streaming, this is just an example. They're paying an effective tax rate of 22%, and that's coming out to X. So, our feeling is, as a committee, is they're giving their fair share into the pot. We're going to go ahead and not move them. We're not even going to include them ever inside. But that's a decision that we get to make, meaning we collectively.
All right.
Okay?
Can I add just to that?
No, please.
Yeah, because I'm with you. I think that's a really important question to know, and I love the way that we're talking about it is in terms of, I'll call it fairness and equity, is an idea of the for-profit investor-owned facilities and what are the actual taxes being paid versus the nonprofits and the actual community benefits that are being driven. The other potential, and until we actually work this whole thing out, we don't really know, at least I don't know how to figure out, is if a certain community only has an investor-owned hospital, are there any unintended, kind of unintended consequences, or maybe a certain city or a market has a large amount of for-profit investor-owned. Is there any weirdness? I'll call it weirdness. Mm-hmm. Is there any weirdness that will occur with carving the for-profits out because they're already providing their support in a different way? And it's more of just kind of almost like a what kind of things can we brainstorm that could occur that we don't want to occur?
Right.
Things that we brainstorm that we want to occur, let's get more of that. Yeah.
Yeah, we definitely don't want to create a system that creates unnatural acts being done
Right.
by the stakeholders.
Yeah.
I can just see all the tax attorneys right now.
But in your sole community provider,
Yeah.
in TALA laws,
I know.
you are going to deliver your fair share, more than your fair share of charity and indigent in that community.
Yeah, no, I tend to
Right.
agree. Yeah. I'm just trying to figure out if there's any, I don't know, when you're kind of creating something innovative and new, it's just that feeling of, let's uncover everything or
Right.
ask every question.
Yeah.
Yeah.
I
Yeah.
think we need to see
And,
numbers.
Yeah.
and I think what that does, we do have some numbers.
Good.
I think that also backs up, and again, not because it's our idea, but why we have to have a pilot year. You know what I mean? Because the pilot year, and I'd love to be able to have it where we will revisit and look at the pilot year. What occurred? Were there any unnatural acts? Did a community that's dominated by for-profit, did it somehow, have, I'll say, adverse effect? Did this have? No one wants to do that, and I don't think any of us are looking for that. But I do believe the pilot year will allow us to have real. I mean, we can model all day. We can get Georgia Tech PhDs to model to our heart's content. But at the end of the day, it's going to be that pilot year that'll give us the best data. At least in my opinion. Yeah. Okay. What's the question, Ethan? Oh, okay, I'm sorry.
not physician-owned. I think it's a hospital authority. It might be a hospital authority now.
County.
County
Just like, I think it's just like Early County.
That's my recollection, but I've got 170 members, so
Yeah.
can't remember the details of it.
Yeah, I have some rural hospitals that are actually,
Can you give her?
they're actually managed by hospital companies, but they are a county facility, so they are still nonprofit. And that's what I wanted to double check on.
I see. So they're managed by a
Managed
third-party
by a
entity.
com- yeah,
Right,
but
exactly.
they are a county facility.
Right, and they get the benefits of a nonprofit.
Right.
Okay, all right, great. All right, this is exactly what I wanted, a working session, not necessarily a pomp and circumstance. Anything else from the committee?
So your major things here is gonna be who is covered,
Yep.
what is the allocations, that's gonna be there, and the unintended consequences.
And then who is covered, I want to bifurcate that. Who is covered in terms of who's providing the benefit? So for instance, nonprofits, profits, ASCs, et cetera. And then who is receiving, or not receiving, but who is going to be calculated into it, meaning is it 138% of FPL and below that we are going to call that indigent care? Or is it 200% of FPL and below that's indigent care, et cetera?
And how are we going to calculate what kind of tax break they're going to get or what benefit? How is this going to work? How is it?
So there won't be a tax break. What it'll be is, it will be basically, this is where the trading, and this is where this is where I hope the genius of the system is.
Well,
is-
explain that
No,
in
no, no.
detail. That's-
Sure. Okay, so here again, not because they're the only two here, so they get picked on for the entire meeting, okay?
I got to see it step by step.
No problem, okay? So let's assume just
Okay.
for a moment, sorry, you're going to be under the floor, okay? And you're going to be over the floor. But let's assume for a moment, we have assigned and we've said that, again, just for the spirit of it, that each one of them has a floor of $1 million of care to indigent people that we've defined as indigent.
And they're going to give that away.
Well, we'd like to think of it as maybe not giving it away,
Well,
but they are
they're gonna
going to,
provide
they're
it.
going to
They're
deliver
going to
those
provide- they're
services.
gonna
That's
provide
correct.
$1 million with.
That's right.
Okay.
It's uncompensated. So to the point that you made, this is Bob Smith. He does not have Medicaid, Medicare, private insurance, or any other means to, quote, pay Emory or doctors.
Okay.
Okay, so for the purposes of this this is a great way to start the conversation, and the PowerPoint goes through it too, is let's assume for a moment that Emory was under, and they're under at 900,000. So they've done all their accounting. At the end of the year, they're 900,000, okay? Miraculously, I know you're gonna find this funny, but they're at 1.1 million. So they're actually even in terms of how they are, quote, over and under. The best marriage that we could have is Emory goes to doctors, calls up. In the first 2 years, we're going to do what are called bilateral contracts. So that's basically a private contract between these two entities. In the third year, we're going to have a market, the same way they have the Chicago Mercantile Exchange. But for the purpose of the first 2 years, okay, Dane will call Teresa, and they will basically determine what he's going to pay her in order to get those credits. And then they will be equal at each one of them now, because Teresa is going to give up the $100,000 of unit value, those credits that she had because she's over. Emory is going to go ahead and pick up that value, and now when they report to the oversight here in Georgia, they're both going to be able to say we were at the floor. Now, my hunch is the cost of it is going to be circa close to what that number would have been if they would have just been, quote, being reimbursed. So whether or not that number is going to be 100,000 that they negotiate, 101,000 or 99,000, my hunch is it'll be somewhere in that vicinity. But at the end of the day, they'll make that on their own, and as long as it's an arm's length transaction, so in other words, it can't be Emory Corporate negotiated with Emory Johns Creek. That's not an arm's length transaction, okay? But they can, in my opinion, as a holding company of Emory, and they have all different kind of locations, they can use each one of them together to kind of consolidate up what their credits are. But that would be the simplest way to describe it. So do you understand that we're not getting a tax break to them? The government's not giving them any money.
How are they benefiting? How?
the benefit is coming from the fact that literally the entire state now, we are providing the indigent care.
The state is going to give them the money?
Now, well, the state will give them the money sometimes because we're going to move this money through the trust fund, so we'll get a match with Medicaid. And so in some ways, yes, the money would be boosted up
Okay,
there, yes.
okay,
But
that's-
I didn't get into
I
that
wanted to
because I
get
was
into
just
the
trying
bucket
to.
of money. Where is the money coming
The
from?
money will primarily initiate out of the person below the floor, the entity below the floor, into the trust fund, get the match, and then move out to the entity who is above the floor,
Okay,
okay?
okay. We're talking big city. Remember, I'm rural.
No. Yeah, I'm just,
picturing county line, one hospital, another one.
exactly. Or it could be Cordele and Northside Forsyth,
Yeah,
right?
right. Could be Moultrie and
It
Ward
could be
County
Moultrie, exactly.
or Thomasville.
That's right. And now I think eventually we won't have bilateral contracts anymore. We'll have the market, but I also think that eventually you'll see the senior executives of all these hospitals coming up with creative ways, maybe through M&A acquisitions, maybe through, a different way of moving the money into hospitals that need capital, and then making some type of agreement that, if I infuse 20 million in, I get X amount of credits back for 5 years, for 10 years. Again, I think if we let the players, which are the stakeholders, do it, I think they'll come up with very, very creative and really logical solutions to solve this problem.
Okay, thank you.
No, please.
So this is, it might be a corollary with investor-owned, and I don't know for sure. As I was reading through the documents, both the Hamilton project as well as the report in the last week, we tied together the idea of nonprofit to provision of charity care. And I've always looked at it as nonprofit to community benefit. And this is where I don't know if there's statutes or if there's even tax code that actually defines this for a state of Georgia. I'm not an expert, I don't know. And so I'm wondering in the idea around this, and this is where, and I'll be, I'll raise my hand and know that I'll be talking about something that not everyone in the state has, maybe in the same way that not everyone's a for-profit, is, potentially the for-profits do pay taxes for their, and maybe as a proxy to the community benefit. There are some aspects, and maybe there's other organizations that have this as well, but I'll just speak for Emory, that the investment that Emory Healthcare makes in the university for the training and research within the School of Medicine and Woodruff Health Sciences is actually very large. And I don't know how we want to handle that. I don't know if it's a concept of, I don't know, because this could make it very complex, by the way. As soon as we define this in terms of community benefit, then I think you have 170 hospitals
benefit for that.
right? But I'm just trying to figure out, because I do think there might be a real issue for the folks that are doing a bunch of teaching and research that doesn't show up in a charity care number, but is certainly a state of Georgia community benefit, almost in the same way that investor-owned organizations provide taxes, that if they were put in this program, we'd be asking them to double count. I don't know, I'll throw it out to you as just an idea that potentially as we work through it over the next few weeks, maybe we can bring some numbers and ideas to it to help educate maybe me and all of us.
So
It's a tough one, though.
It is. So my pause is not because
Sure.
I think it's crazy. My pause is that's a fair. My challenge there, complete disclosure, Dane, is
Yeah.
this: is respectfully when Emory says to me, "I'm doing a contribution into teaching."
Yeah.
I'm pretty convinced you are because that's what you do. That's your charter. Others tell me that, and I have to admit, I look at it with a jaundiced eye.
Sure.
Okay. And I'm not the arbiter here. I'm not judge,
Yeah,
jury, and
yeah.
executioner here. But at the end of the day, I think if we're going to take that, then we need to seriously look at, and I don't know if I want to get into the who is justifiable in that versus who isn't.
I know.
Because now suddenly it's exactly what we don't want this to become, which is this whole idea was let's set the football field and let Coach Smart and Coach Saban coach it. You know what I mean? And however it works, it works.
Yeah.
If we start, saying, well, you get 3 downs instead of 4 downs for a first down, let's absolutely put it onto the list
Yep.
because I think it's something that's fair. And I think those of you who are legitimately in that pot, which by the way, I don't believe that's a big number in that pot.
Right.
I think you do have a argument to be made that's justifiable and one that should be considered. So I want to put that in. Again,
Yeah.
your bucket's becoming the biggest bucket, by the way,
Yeah.
the Dane bucket.
Well, because
So
I think, and that's the price of innovation. I think,
it is.
right. It's innovation is hard, but it's also the opportunity to really have step function changes in performance, and that's why it's valuable to spend the time on innovation, because continuous improvement may not get us to where we want to go, and it takes the innovation piece to really get a big check.
And that's what I
Thank
want
you.
out of this, by the way,
Thank you.
is our big chunks of innovation. Because when GHA talked about last time about innovation, and we were talking about, in 30 years, it's been basically e-charting, I appreciated their candor. I really did. But I think all of us would hope that we can even help the GHA's member institutions to have the motivation to even see what we can do in terms of bigger steps,
Great.
kind of more moon landing type stuff.
Thank you, Mr. Chair. So, really just wondering, talking on that community benefit line, what our goal, I think, as I understand it here, would be to increase the indigent care or offset the balance of the indigent care, where community benefit wouldn't necessarily come into that definition, as far as I've understood the project so far. And are we open to having the discussion on indigent care and not being in the hospital business, but is there any sort of measure of preventative care in that 3% of DCA or the DCH requirement? I feel like that's mostly cost inflated due to the emergency room as a primary care facility. And potentially we could look at some of this and actually create better benefits for our citizens if you look at preventative care in some aspect of that. I think everybody in the business actually understands that a lot better than I do. And within the definition of indigent, let's not say, hey, it's just your ER bill, because what if you keep that person out of the ER? Then it's going to cost you a lot less and be a lot more efficient. And that's, I think, what we're going for is efficiency and innovation. And so let's not leave that off the table.
I agree, and maybe to the gentleman to your right may
Yes.
have an opinion
Yes.
on that.
I'll need to look into it.
Okay.
Because there's some flexibility, but not total flexibility. And so let me get a better answer for you. And I'll be prepared for the next meeting to give you a better answer.
Would that be something that we could shoot out in an email to the committee because we're coming short on time?
Absolutely.
Would that be okay? If you don't have the emails, we can arrange to
I've
get
got
that to
'em.
you. Okay, thank you. I appreciate that. All right.
One other comment.
No, please, this is meant to be a working session.
Sorry, it's working, and my brain is kicked in, sorry. When we talked about the education, because of our rural council, we are now getting opportunities to have training of physicians through internships and residency in rural Georgia. So this is kind of new to some of us. Some of the hospitals have had them for a while, but I want to make sure that that's not going to handicap. Again, I'm looking out for rural today. And we've got to, so I want to make sure we don't overlook that and let everybody have the opportunity to have it.
Absolutely.
Don't take it away.
No,
That's-
a big driver of this is rule. There's no doubt about
Okay.
that. So we
That-
do not
that's-
want to do anything that would somehow hamstring them even more so than where they're at today. We
Right.
want to help. We do not
Right.
want to
This is a
put,
big leap that we're getting some great opportunities and make
Right.
sure whatever we're doing, again, unintended consequences so that it doesn't disrupt that movement that we've got.
yeah. And again, I just want to keep coming back to, that's why I do think the 1-year pilot is so important, because we do need to work out. I don't think, we could spend 2 years doing working sessions, and I don't think we'll get as much data out of it than that pilot in terms of what we can learn from it. Okay, anyone else on the committee? I asked this hesitantly. Is there anyone out in the audience right now who you're thinking, wow, they need to put this down as a big thinking item? Would you mind coming up, David, to the... Yeah. And David, if you don't mind, could you do this in the spirit of these are things that we need to be considering as we go through this session, please?
certainly, because you and I have had a couple of these conversations already. And I've been dealing with Indigent Care Trust Fund and Indigent Care and Medicaid for nearly 30 years. And I love this as an innovative idea. And the nuts and bolts, though, I always have a question about. Initially, when we spoke about this, you indicated you wanted to run these through an exchange that would go through the Indigent Care Trust Fund, correct? Therefore, draw down a federal match. My recollection is that private hospitals can only participate in the Indigent Care Trust Fund if they have a proxy for an intergovernmental transfer. Public hospitals can make intergovernmental transfers into the fund. Private hospitals cannot, which is why I think for the past dozen years or so, the General Assembly has always made an appropriation in the amended budget for private hospital, DISH, or Indigent Care Trust Fund. If you have a private hospital that is buying credits from another private hospital, or a private hospital buying credits from a public hospital, I don't know how CMS would consider that to be if it's private hospital money, if it's got to be an intergovernmental transfer to qualify for the Indigent Care Trust Fund to draw the money down. It's something I think you need to think about.
Absolutely.
Because CMS is going to have to sign off on any of this. And it's just something that is a issue. Two, DRG is used as a reference point, and I think it's a good one, but my recollection is DRGs usually apply to hospital inpatient care. Outpatient is a huge part of what hospitals provide. And of course, if you're talking about ambulatory surgery centers, which I heard mentioned at the beginning of the meeting, those are more CPT codes. And I think you need to figure out a way to have some equivalency or some calculation that takes in that. Otherwise, a lot of hospitals do a lot of outpatient business, and they experience a lot of indigent care in that outpatient business. And you got to figure out a way to calculate that. And the other thing I didn't understand earlier in the meeting, and I apologize for this, is you mentioned a situation where a hospital would potentially decide, I don't want to do indigent care. I'll just buy my indigent credits from a hospital that's doing indigent care, and that'll be it. I just won't have to do much indigent care. And you said there'll be a penalty if they don't hit a floor. But I'm scratching my head, if they don't hit the floor, if they do hit the floor, then why do they need to buy the indigent care credits? I'm struggling with that. I'm not trying to be negative. I'm just struggling with that.
It's a great point, and David, let me clarify that real quick. If what I meant to say, and my apologies, now that I'm playing it back in my head, I see where the confusion came from. If say the reporting for December 31st, say the reporting is, I won't say April 15th because that day is harsh to all of us. We'll just say April 30th. Say the reporting day is April 30th for everyone who's covered, meaning every entity that's covered, okay? So everyone has to report where you are at the floor. Were you at it, over it, or hope not under it? If your report on April 30th is that you're under it, then it's the cost of the abatement plus the penalty. But if you, between January 1st and December 31st, got over the floor either through your own care or through some type of bilateral contract that you made, maybe CHOA with Emory, then God bless, you're at the floor, and when you report on April 30th, you're there, then there is no penalty. It's only if you report, and I apologize, that's a great comment, only if you report on the 30th of April, in that example, that you're under, then you would have to pay the cost of abatement plus the penalty.
So the penalty's on top of getting current with your...
Exactly. What we don't want, and again, I don't even want to use a hospital here in Georgia because I'm not even believing anyone would do it, but ABC Hospital decides, you know what, the heck with it, I'll just pay what I got to pay on April 30th, almost like when we pay on April 15th. And at the end of the day, the fact of the matter is, no, we want people participating in this. We want people to figure out ways to be more, to Representative Fry's point, innovative and efficient on doing indigent care. And the only way to do that is that every player that's inside of this system is participating in it. We don't want people just folding their arms and saying, I'll cash a check for them. And we want to give them an incentive, and that incentive is do it, or we will do the cost of abatement plus a penalty.
That makes more sense.
Okay, thank you. And I apologize, and thanks for the clarification.
Thank you.
All right. Now, I really, really do appreciate the open and candor. Anyone else from the audience? You don't have to live in my district to get up there. He lives in my district. All right. What do we think is a good use of time, guys? Is it we don't have to be married to the agenda. Is it going through the PowerPoint? Is it and talking about some of the things that we've discussed today in terms of key points? Is that a good use of time? I don't think we need to go through like the first 6 or 7 slides because that just kind of sets the problem. I think we could actually jump to, I'll call it the solution. I'm open. I don't want people to feel as if. Do the first ones quickly, and then when we get to, I'll say, the implementation part, then we'll slow down and talk about some of the things that we've discussed in the first 45 minutes or hour. Okay, great. All right. For those of you at home, we'll make sure that this is available electronically, but the first page is pretty important. This is work in progress, and please note that please get the latest version because we do expect this to change nearly on a daily basis. And if you're using this for your own internal purposes with your boards, or if you are from the press, we would appreciate you getting the most updated version. The next slide. So Representative Taylor oh, there we go. Keep going, please. All right, and I can't read that far, sorry. All right, so the whole idea was that we wanted to give everyone just the origin of what we wanted to do here. We just talked a little bit about the challenge project, or the challenge that we have, Representative Taylor, in terms of how many uninsured we have, what's provided by, who gives it, what are the benefits, and some of the things in terms of the demand for the uncompensated care is the highest in our poorer communities. And basically how it is that we can align capital. And right now, capital probably is not completely aligned, and how we could align capital to where it is, where the need is greatest, and then where we can provide the support. Oh, please, Dane.
And it's just a question. I think I get the geographic mismatch. I think that's a pretty neat way of looking at it and getting that in my head. What I don't know exactly is how we're defining largest tax benefits, which is in the middle of the page. And I just don't know if it's the belief around the amount of community benefit versus, I don't even know what it would be. So if there's a way to define that, I think the committee, maybe I'll talk for myself. I would do a better job of knowing how to balance this idea of geographic. If I knew how we're all defining what largest tax benefit, how it was defined, what it meant.
Okay, so yeah, and again, this is a little bit of hyperbole, and I don't mean hyperbole in terms of dishonest, but
sure.
Trying to just basically, you're trying to in one slide set a problem that in my opinion probably takes a thesis paper.
Sure.
And trying to do it in 3 paragraphs. So just from the largest tax benefits, that might have been too strong of a statement, but basically we started to look at some of those hospitals that sit in certain areas within the state, certain metro Atlanta areas, certain mountain areas and things like that. And when you start looking at just even the property tax abatement that they receive is massive compared to some of the rural areas. And you look at that property tax abatement and is much smaller. So again, if you'd like, I'm happy to define that. But by no means was that meant to be a poke at the bear. It was more along the lines of just trying to give that. Does that help?
Actually, the property tax abatement actually is that makes some intuitive sense.
Yeah.
That's helpful.
Okay, thank you. Representative Taylor.
Okay, when you have hospitals today, whether they're in a large city or small, they own more than just their hospital
Yes.
building. So
Very much.
That's another place. Is it going to include every piece of property they own? Or is it going to, they might own the property across town where they have a clinic, or they may have a standalone ER, but it's still nonprofit and it's still part of their package, although it's not right there at the hospital.
I think it's up to us to define it, and I'll use
Yeah.
Northside as an example, just because that's my home hospital. Northside obviously has the hospital, but I know they also have urgent care. They also have ASCs, and I don't know what other entities
Right.
they have. So our decision needs to be, what are we going to say as part of the stakeholders? Is it the entire, I'll say, complex, and I mean complex by generally speaking, the
campus,
Northside
main
brand,
campus.
or is it just the hospital per se? I think that's a question for the committee that we can make.
Okay,
Okay.
thank you.
You're welcome. The next slide, and again, these are gross revenues. These are not net revenues, and this was just a proxy. I want to stress that it's so important that we're not going to, I do not believe this will be how we define the floor for the record, but we needed to come up with a proxy. And as we were looking at, there's a lot of public data around nonprofits, a ton of public data, and we started to look, and generally speaking, it seems to be about 7%. I'm sure there's arguments to be made that it's 5, others that it's 9, but at the end of the day, it was 7. So we wanted to give everyone just a sense how many beds, hospital stays, and what number of days of care. Next slide. I probably should have used the word challenge and not problem, but ultimately, and we hit geographic mismatch already, the disparity in eligibility, and this really comes around to, for instance, where the threshold is on FPL, and everyone is constantly having the argument, may it be on Medicaid waivers, Medicaid expansion, et cetera, and I think that actually confuses the issue, and then accountability standards in terms of no standard framework for the current amount of reporting that we currently do in Georgia. There's no audit against that. So basically, the standards are looser, and how it is that we can basically create a market framework where, in fact, the market is basically holding them accountable. Next. Now I'll slow down just for a moment because now we're getting into the solution. Representative Taylor, was that okay? Okay, great. So we need to be able to set the threshold. So Georgia will set the income threshold as the family income above which uncompensated care does not count towards charity care provision. I keep using FPL. I've been assuming everyone knows federal poverty level, but ultimately that seems to be where most people are most comfortable. And we talk normally around 100, 138, but I want to stress, like I said in the beginning, we're not tied to 100 or 138 because there is no, quote, federal government entity that's overlording this framework. We can define charitable care, people where we're going to count charitable care as what we think is right for the state of Georgia. Second, defining the floor. Like I mentioned, I think it's important that we do, in fact, decide what the floor is. I think one of the things we may want to consider, and so I hope everyone's listening to this part, do we ask whatever entities are covered, and again, just for the purposes of the conversation, just say the nonprofits are covered, do we ask them in the bill within 90 days, 120 days, you have to report based on the unit of care that we've said, so in this case, say DRG for inpatient, what your level of charitable care was last year. In other words, this way we can get an apples to apples comparison as opposed to some assumption being made that Emory did one thing and Northside did another thing. Do you see what I'm saying? Because today we don't have those numbers. And again, I'm not picking on anyone, it's just a fact, because we would be creating a standard to the point that David just made. Okay, may it be CPT, may it be DRG, may it be whatever it may be. The fact is we're going to have to ask those nonprofits, please tell us, what did you do in 19? What did you do in 18?
So in the annual hospital financial survey, we do report what our definition of charity care is, and we report that in that survey now. We have those numbers now.
And that's what we took most of this information from, but I think the key phrase there was our standard.
Right.
If we come up with one that is even slightly different, we'll have to ask for a slight modification so we make sure, because I don't want to penalize anyone, I guess is my point.
Right.
Whatever unit of currency we decide is the right unit of currency, let's just make sure that no one gets penalized.
Okay, so I'm a little bit confused, and I'm sorry. I'm a CFO and accountant. It's who qualifies according to your charity definitions in your facility. You can count at any unit you want to, but it's who we qualify.
Right.
And so you're going to have to go back and say, okay, what you're going to have to count as charity care is if you qualify to everybody under the 38% of the FPL.
If that's the standard we
If
decide.
that's the standard we decide. And that, you can't go back and get that, because at the time, you qualify that patient based on your charity care definition.
Then we're going to have to, and we got to figure out a way.
Right.
I don't want the baseline, and I mean this wholeheartedly.
Right.
I do not want the baseline to cause an adverse effect
Right.
to, I'll say, operations.
Right.
I always wanted this to be part of something that just kind of moved along with current operations, not causing anyone brain damage. And I definitely don't want a Sarbanes-Oxley thing where everyone has to hire 50 accountants and lawyers just to make the government happy.
Right.
Okay? All right. Yeah.
Sort of where I was going also, going back actually to first column.
Oh,
When we set this income threshold, are these patients going to have to enroll in something and get an ID card so the hospital will know? Or do they just show up? And how,
Tried that at Grady with the Grady card, right?
Yeah.
Do they still have that?
I don't know. We need to find out if it worked. I'm just trying to figure out how are they going to know, because it may be a different threshold at a different hospital. And how are they going to identify themselves when they show up for the care?
okay. Hold
There's
on.
got to be some way for each hospital to know and be able to identify that patient.
Well, we want to make that as easy as possible. And I don't
Right,
know,
'cause they'll
Dana
never-
Teresa, do you have a thought on that?
Well, it changes. I mean, a patient could get employed and then not meet those federal poverty guidelines. It's an application every time you receive service, whether it's outpatient surgery, whether it's in one of your clinics, whether it's an inpatient admission. It's an application by that patient, and we're gonna have to determine the standardized definition of what charity care is here in the state of Georgia. We qualify our patients, for instance, up to 400% of the federal poverty level. And so, I mean, and some don't. I mean, we've seen the numbers here in Georgia, where some is very low and some is very high, but that's what we're gonna have to standardize. But each time a patient receives service, they are going to have to give you that financial information in order to qualify them for charity care.
Yeah, that's, and Teresa's right, that's exactly right. What I was gonna mention is, as we think about where to set this, it almost feels like we'll need to, and I'm thinking testing in the model, not testing in the pilot phase, because then it's a step too late, is if we set it at 138, what things happen above and below? If we set it at 200, what happens above and below?
Yep.
And then what'll be great is then we can actually make an informed decision around, okay, the optimum is 200 because X, or because of some reason. But Teresa's right, I've not actually, I don't know if GHA's done a study of, or if we even report, do you know, because I'm not the CFO, does each hospital report its own, 400% of FPL for their charity? Is that on the?
It's on our GL.
Is
Yeah, I mean, we report what our charity care is.
right, but the policy is the policy.
Right, and
is
then
that,
they're not standardized.
No.
Right.
Are they
Amongst
are they communicated to like GHA or?
Probably not,
I don't
because
think
ours is
so.
proprietary.
Yeah, I hear you. Yeah, so that'd be one of the challenges is that we have variety. We have a different one.
We talked
and
about that in the Hamilton project.
Yes.
yes,
It-
and,
Yeah.
and, and that was the
It
purpose
definitely
of.
hones in on this.
It does.
About who, what,
And that goes back to the slide where I talk about accountability standards. And again, it wasn't a poke at the bear. It was just, I was reading it
Yeah.
and I'm like, oh my gosh, there's not just one set standard. Everyone in a sense gets to be their own judge and jury.
Right.
Supervisor Taylor?
It goes back to the same thing, if you have some way to re-verify, but that becomes a monumental task, either if you do it at the state level, where you give them the eligibility. Some health plans do it, they verify you for 6 months. You check your hours, you've worked, you become eligible, and so you're good for the next 6 months. But to do that here,
In the pilot-
somebody has a heart attack, the hospital fixes them, and 2 months later, they're back at work, or they're fine, and so they don't need it
We
anymore.
gotta start somewhere.
Yeah.
So why wouldn't you start with what we are qualifying for charity in our facilities now?
Everyone's different.
Right, everyone's different, and it could be at 400%, it could be at 138%, but what we're reporting now, we could start there, and we could model that now, and we could see what those numbers look like. I think the floor we're talking about establishing, and maybe I've just missed this, is you're gonna require each hospital to provide a percentage of their operating cost of charity care. Right? Like let's just say 3%.
Generally
And
speaking,
then we're gonna trade back and forth, so we all hit 3%, right?
give or take.
Give or take. And so we've also got to define what the cost of that charity care is. The
Right.
easiest way to do that is what we're already reporting on our cost to charge ratios in the Medicare cost report.
Yeah, I think that's right. And if I go back to the Hamilton project, that at least where they would argue against that perspective is, we'll just say rich hospital and poor hospital, just for grins instead of. So rich hospital says I can afford to get everyone to under 400% of FPL. So the people of that community have folks that are at the 300% level get this enormous benefit and don't have the debt associated with it. Poor hospital doesn't have the financial wherewithal to go to 400%, so they get a 138. So now I got a patient that's at 150 who gets big bill, 10 miles away from patient who's at 300 who gets no bill. So that was the issue in the Hamlin project.
Right.
Yeah. Now, but that doesn't mean it's easy to fix. It just means that it's a challenge.
For us.
Yeah.
There's also an issue, also, some of the smaller rural hospitals do not have big dollar, they're not gonna have big expenses. They don't do heart surgery. You're gonna do you could do transplants, you could do cancer treatments, and some of the other hospitals are. They have high dollars, high volume of claims, but maybe not in the dollar amount. Is that making sense?
Oh,
How do we take that into consideration too, if you're looking at only dollars? I mean, dollars are the important part, don't get me wrong, but you still have to have the basic infrastructure in that hospital, even though you're not able to do the high dollar.
I would argue that some of our hospital systems have the leverage of shared services and efficiencies that they've really driven their operating costs down.
Right, where a single small hospital,
Right, for a single small hospital doesn't have the
they
advantage
they
of
don't have
that.
it, right. So that's gotta be in the equation too. Sorry, but it just does. I don't know how you put it in there, but I feel like that's another,
So basically, we're talking about scale.
somehow you've got to look at the scale of what facilities are. Some have little more than swing beds, they might be able to do appendix or deliver a baby, but they're not gonna do big cancer treatments, they're not gonna do major surgeries, they're not gonna do hearts. So they don't have, those high dollars. Most of those treatments are paid. So I'm not sure, but I think it needs to be considered in the fact.
Have you thought? I'm sorry, Representative Green.
A lot of them are already way over, these small, way over the floor.
Oh, yeah.
Right, yeah.
So how, we've got we don't have a problem, we have an issue that we've got to resolve here.
It just needs to be incorporated in it when we're looking at it. We've got to look at that
So
part too.
so scale.
It's a scale.
Okay.
Somehow there has to be a scale of the facilities and what they're able to provide.
Okay.
And like she said, some of the smaller hospitals don't have the benefit of having the same volume. It's, volume, with volume, your costs go down
Sure.
okay. They don't have the volume, so their cost is going to be a little bit higher anyway.
Okay. So their per unit is higher.
Right.
Okay.
That's correct.
Got it. All right. Representative Fry.
Thank you. I've got an accounting question for the hospital experts in the room. So when you talk about, because it almost seems like we're talking about uncompensated care, because in the idea that, and correct me if I'm wrong where you go, in order to do like a financial check at 138 of the federal poverty level on every single individual that walks in the room, I don't know how y'all do that. First off, I do it every day in my business, but on the volume of a hospital, I don't know how you could monitor that and how you could set that.
We do a registration. And if a patient if they're uninsured, then we do an application on them. We get all this information.
Right. And so you're actually doing an intake on every single individual.
We have to.
But
Okay.
it wouldn't be everyone. So I don't know what the percentage is, and I think
But it'd be the uninsured ones.
it'd be the
right?
uninsured and the no Medicaid, no Medicare. Yes.
Right.
But I don't. So
Credit or verification?
sorry.
And so you do, and is it involved in as seeing their tax
Yes,
returns
yes,
and
they have to
paycheck
give us- they have
stubs?
to give us certain, if they're applying for financial assistance
Okay.
and qualifying under our charity guidelines, then they have to produce certain documentation.
So you do a full-blown intake to
Full-blown
monitor that?
intake,
Okay.
yes.
Now, so is that when there are no collections sold to a collections agency for that customer, as if they qualified for your definition of
This
the?
happens at the time of service.
Okay, so it happens at the time of service, and then there's a bill,
Mm-hmm.
and then it doesn't get paid, or y'all just go ahead and count that against your
Well, if it
threshold?
meets charity, we don't bill them.
Okay, you don't bill
That's
it.
written off to charity.
Okay.
If they meet our charity guidelines.
Okay, so here's a question I got, and pardon my ignorance. So I see credit reports constantly that have hospital collections on them, but these are people that are below. I mean, federal poverty, as we know, is ridiculous. $1,000 a month. That hadn't been changed in like 40 or 50 years, right? Okay, so but they're below any sort of real concept of poverty, but they have hospital bill collections on their credit reports. So that means they didn't qualify at
Well,
somebody's.
it could be that they came in.
Or they didn't
came in,
apply.
So they were seen in the ER and then they won't answer our phone calls or anything like that, and so then they never apply.
Okay, so then they get the bill on their credit report. Now, and y'all write that off, or you sell that to a collections agency? Do you make money off of selling those? Some people do, I think.
Yes.
Right?
We do. And
Okay,
we
so if
go
you have
in hindsight, or we write those off. I mean, it's only in rare, we have our own collections department.
Yeah.
It's only in rare that we will go after smaller dollar amounts for collections.
Okay.
We probably have one of the most generous write-off and charity care policies there are.
And that's just one hospital organization within the, and I'm just trying to get my head around this. I'm just
Right.
trying. So then,
But you wouldn't go after, you wouldn't try to collect from somebody who has become eligible for indigent
No,
charity
we
care.
would not.
right.
So they're not in that collection group.
Right. So so just as a one data point from me, is there's a bunch of people who are not offering any sort of charity care for very small hospital bills because they're showing up on everybody's credit these days. By the way, I want everybody to understand that. And then if we're going to talk about the credits for that, if you sell a bill to a collection agency, then your credit can't be for the bill. It has to be for the net.
It has to be for the cost of the care of providing that.
You see what I'm, but you get
Right, but-
credit
Not
against.
first charges, it's for the cost of the care.
Right, and that's
Yes.
why we wanted to get a normalized unit as opposed to.
Well, I mean, if you sell the debt, then you don't get to get money for the debt and then also count that debt that you sold towards
I see
this
what you're saying.
indigent care.
I understand what you're saying.
It has to be a net.
But I think, and again, I won't speak for Teresa, she can speak for herself. But the fact of the matter is we're looking to do this on a cost basis, not on a revenue basis. So at the end of the day, there's something built in there in terms of a margin. At least, is that a fair statement? Okay.
Yeah, I'm not talking about the margin. I'm just talking about
Right.
if you're making money on selling the debt, you don't get to count that debt that you sold as for your full indigent care credit.
I do think the Kellogg professors in the report do a really good, I don't remember what page it's on, but they do a really good analysis of this exact issue in terms of if you relieve the collection, and now suddenly what does that do in terms of the uncompensated care? And then in terms of being able to, what does that do for society? What does it do for the person? And then what does it do for the hospital? Or the provider, I shouldn't say hospital. Right. Okay?
But even if you write off the uncompensated care, if that person did not qualify for the indigent care funds, you're leaving them alone if they didn't qualify to begin with. No.
No.
The hospital will go after them,
Right.
and the collection agency may get something, but that's usually not, it's the cost. But even that usually doesn't materialize to where you're collecting the full amount of the cost to deliver that service.
Oh, no, never.
so-
And I'm not suggesting
yeah.
that. I'm saying like, on a $10,000 procedure, you might sell the debt for $500.
Right.
That's
or whatever.
your net is your 9,500 indigent care.
Understood.
Right.
And what I'm getting at is, and again, I understand everything that Teresa's saying, assuming for a moment you know that that individual is wherever it is that we define indigent at, then there shouldn't even be that conversation.
Yeah, okay. All right.
Okay?
Now
So we
that's
shouldn't
making
even-
a very good point.
You know what I'm
So-
saying? Like, we shouldn't even be having the conversation about it because they were underneath
So
and
the
they weren't
poorest,
covered.
So the poorest person in the world could walk in, have a $10,000 bill, and if they didn't fill out that paperwork, then that's not your indigent care value. It's only the ones that actually fill out the paperwork that are going to count towards
can
this system.
Well, it's the only way that we would know they're
to capture
legitimately
it.
at
Right.
138 or 200 or whatever number we're going to put against FPL. You
Gotcha.
got to know. I mean,
No, that's perfect. I
in,
got
in
you.
return
I get
for
it.
that care, I think it's fair. I think society would want to know you, in fact, did in fact qualify.
Absolutely. That's
Okay.
what I'm just making sure of,
And
that
if-
it's not
And
counted
if
as
you're,
uncompensated.
If you don't want to fill out the paperwork and you don't want to bother with cooperating with us, then that's why we do.
No,
turn
no,
it
I got you. I understand. I'm
It's
just trying to-
similar to
But you
Medicaid
wouldn't-
applications.
right.
That's
If you
exactly
don't
what it
apply
is.
for Medicaid,
That's
Don't
right.
get it.
you don't
There's
get
so many
Medicaid.
people that don't apply for Medicaid, and
Right.
they qualify for it.
But let me be clear, though. What Teresa's saying, they wouldn't even go into the calculations of the floor.
That's what I'm talking about.
In other words,
Yeah,
she,
that's right.
the doctors wouldn't be able to say that they should go into the floor because we don't know. So with all due respect, they should be billed.
Yeah,
Yeah.
no, okay,
Yeah.
thank you for that clarification. I'm just trying
Okay.
to, I didn't
All right.
know you guys did intake on every single individual to that extent. That's pretty,
Well, I think it's every single individual that doesn't have coverage.
We
Is
have
that- is
every
it-
single individual, period. I mean, we are going to get
Wait.
insurance information.
Oh, yeah,
We're
yeah.
gonna have to get, a lot of information on registration. We have to do that.
But you don't get my.
yeah, but I've
income and
never done
everything.
any financial
Other
documents
than
at the
my-
doctor.
Because I'm insured.
If you have insurance
Right.
information, only if, you're telling us you can't pay for it, then we're gonna want you to
Understood.
apply
Right,
for
I
financial
got you.
assistance.
Okay,
Dan?
thank you for that
Yeah,
clarification.
I'm really glad we walked down that. I had not thought about the concept of that if someone walks in, can't pay, doesn't engage with the healthcare system, that's not a part of the, I'll call it the community benefit that organization is providing the community. Ooh, that one actually, it is, but it's not gonna get counted.
And you do have
So
an ER
that's
guy
an
that
in-
comes in, has a heart attack, and you never see him again.
So that's going to be interesting. Now, it may be a situation where we can talk about that as potentially, I'm going to use the word noise. So if there's a way to get at this concept, because Teresa's so glad we have a CFO on the team, because we couldn't answer those questions without you. But if we could figure out how many folks actually come in, are indigent, are poor, don't engage. If it's a relatively small number or small percentage, you could call it net noise and just say, you know what, that's why we have pilot years.
Right.
If it turns out to be some larger percent, then that's like a whoa, that's a risk. But
And that's
yeah, maybe we
that's
should
my
figure it out.
supposition that actually this may be a more robust program to consider it as an uncompensated care program as opposed to an indigent care program, and the idea that I think there's a lot of that going on. Basically,
Interesting.
and that's where our rural hospitals are an issue. Honestly, I love the urban areas, but that's not why I'm here doing this. It's because we have rural hospitals that are closing because of uncompensated / indigent care, whatever you want to call it. It's no money going out there.
But I do think that
Yeah.
those two are maybe not interchangeable in this conversation.
think
but
they're
darn
almost
close.
interchangeable.
Yeah, no, they're down close. I agree.
Yeah.
Sorry, Representative Taylor.
I think it might be where you could have, when we do our definition, have an exemption of another category. When you can't find them, they're gone, they disappeared, and it's truly uncompensated, and that does happen.
Oh, yeah.
So let that be a credit account somewheres, because that's got to be accounted for. Again, all hospitals have that.
Yes.
Where you can't find them, they're admitted through the ER, they could be unconscious when they come in and they're gone the next day. But those dollars are,
Are real dollars.
they're real dollars, and
Yep.
that hospital has expended that money and provided that care, and it is a service to the community. So they need to somehow have a factor to include that in there.
That's exactly
Right.
what I'm
As
trying to
So,
get
another
at.
is there-
category. Call it the uncompensated, not just the charity. Does that make sense?
It does.
And maybe, even if it doesn't get full credit, it gets something.
I mean, I would think that the most people who aren't paying their bills can't pay their bills.
Right. That's right.
And so I feel like, I mean, I'm sure there's bad apples in every single group, and there's somebody with a bunch of money that's not paying their bills.
That's the
But I
exception.
feel like that's the exception to the rule, and the rule pretty much is there's a bunch of hospitals that don't get paid for the services they provide, and that this program may not even need a poverty level measure. And I'm just throwing that out. I don't have any decisions because you know the business model
We
better.
have buckets. We have buckets of uncompensated care, uninsured, and we have charity, and then we have true bad debt, the ones that could pay that we can't collect.
Right.
And so we can decide that we're going to include charity and the uninsured. Because you have that group of uninsured that are over the federal poverty that's not going to meet the charity guidelines.
Right. And that's why I said I think it's up to us to decide
Right.
where that threshold should go to for that second bucket, Teresa. Again, I think at some point we need to have some definition there. I don't want it to be
Right.
laissez-faire or to be amorphous, amoebic-like.
Yeah.
Yeah.
I like the concept of the buckets, and maybe we do need to think about two paths for different types of individuals. We have the Indigent and Charity Care Trust Fund now, which we could redefine, keep defined as is. You have a floor and trade exchange, and do you have different populations that go or access each of those? Or do you do away, I don't know that I don't know the value of doing away with something that's not totally broken. And so, but do you come up with new definitions of who gets what and what are the thresholds?
Meaning that you would kind of add, we're talking about indigent care, that we would add an uncompensated care
Right.
category to this.
Yeah,
Plan.
now there's danger with that.
Sure is, sure is.
There's danger with that. But it's something to think about.
Dane, Teresa, is there a proxy? And again, this is a general statement, not 100 out of 100. Is there a proxy that if a person is eligible for this program, 92% of the time they're going to most likely be 200% below FPL? Again, I'm just making up that type of correlation. Is there any proxy, like any federal program or state program, that eligibility in one of those pretty much tells us they would be in this pool of people? And again, I'm not saying 100, I'm saying 90 out of 100. No?
It's not ringing a bell, but.
It's not ringing a bell?
We'll take it
They tried
back.
to do that with food stamps and WIC and Medicaid, and it didn't work.
It didn't work, okay.
They tried to put them all, if you qualify for this, you automatically get that, and I think it didn't work.
Okay. I was just trying to come up with
Yeah.
a way to do it.
I know.
Why didn't that work?
I just don't want brain damage.
I'd like
I'm
to see
trying
why
to
it didn't work.
limit brain damage. Okay. Can I want to keep going on the deck?
Yep.
We're flying through this thing. All right. Defining the floor, Teresa just commented on that. But I do think it's important that we take a look at what are, what's happening today. We did take a look at the reports that Teresa referenced about a half hour ago, and that's where we came up with that model, and you'll see it momentarily. But that was the only data we had in terms of the amount of care that's being given by the hospitals today. But I do think the floor is important. And then finally, the exchange. So we'll have to come up with, again, let's just assume for a moment, just for mathematical purposes being easy, the floor is 1 billion, and I'm using one just because it's, or how about 10 billion? It's easier to divide. The fact is we do need to come up with how many units we would put into that 10 billion. Again, hypothetically, you could have 10 billion units, and you have each one's worth $1, and then any other divisor that we could use. But ultimately, keep in mind, everybody, we're kind of fixated on the first year. The whole idea of this program is to create urgency, efficiency, and innovation. So if the floor this year is, say, 10 billion, maybe in 2 years it's 10.2 billion. In 10 years it's 11 billion. The point being is we have to be able to set something that works for the stakeholders. We don't want to squeeze down the stakeholders. No one's looking to do that, but ultimately also get to the overall societal good that we're trying to create. And then finally on the exchange, I've mentioned it already, by the third year, at least in my opinion, we need to be very much Chicago mercantile. In other words, you can just go out and pick up what you need, buy what you need, sell what you need. And for the CFOs in the room, if you guys need to put some type of collar, short, long, derivative, or something like that, that's up to you guys, because you guys might be making some type of play that you need to have that level of flexibility next year. The one other thing I will give you guys something to think of, I believe that we need to be doing this like in 3-year periods, because let's face it, and sorry, Emory, you're here. Emory may say the first year is 2022, and so it's 2022, 2023, 2024. Okay, we want to give Emory and all of the hospitals, we want to give them the flexibility that this year they might be a little short, but that's okay. They can go into next year. But by 2024, there needs to be an evening up. So you can pull from 2023 if you want, even 2024 if you want, but come 2024, there needs to be something. I'm concerned, everybody, that if we do this in 12-month increments instead of something like 24, 36, or 48, that we cause almost a constraint on capital, and possibly we also cause unnatural acts by our stakeholders, and we do not want the stakeholders doing something unnatural just to be able to meet this. But I do think a window of 24, 36, 48 months gives everyone a good enough view so that they can move in and out with a little bit more flexibility. Does that, I see a lot of head nodding, so that's good. Anyone nodding no to that type of window? All right, good. Oh, we have a question. Representative Frye.
Thank you, Mr. Chair. So to the hospital folks in the room, have we seen, and I think I've heard this, a relative increase of the indigent care / uncompensated care over the years? And one of the things I think we need to be aware of, and I'm not a stock guy, but what about the more, I guess the more that it increases, the less valuable they would be over time, is that correct? And then where we might be building a system where all of a sudden it's really not working as much because rural hospitals are.
Recession hits, you're gonna have a problem.
With the recession hitting, are you suggest? And again, I'm not trying to be funny here.
I'm just-
Why?
If you hit a
Why?
Recession, all of a sudden, everybody's indigent care is going to go up. I saw that in my district.
That's right.
Indigent care, the factories closed, people no longer had their health insurance that was payable. It either became Medicaid, or if they didn't qualify, they had nothing.
So if you have a finite, if it had a stable market year after year, we did 100 units of credit per year, and then, but we've seen an increase, so it's going 110, 120, 130. And then, like Emory might need some credits, but actually it's up to 140. So then Darlene's district has a hospital that can't sell the credits because they've already bought all the credits they needed. How does that account, how could that be accounted for?
Well, hold on. We would release, and again, sorry, everyone, say 2022 is the first year. Say we agree, and again, just for math purposes, the floor is 10 billion, and we're going to do 100 million units, just for easy math, okay? The 100 million gets allocated based on what you have done over the last 3 years. Okay, so Emory would get of those 100 million. Sorry, Emory would get 1 million, and doctors would get 500,000, and Northside would get 1 million, and et cetera, et cetera, et cetera. And at that point, then that's it. In other words, we don't release any more allocation for that 3-year, or 2-year, or 4-year period. So they either become more valuable, or they become less valuable, or they stay the same, depending on where things go. And again, there's a lot of macroeconomic issues that could cause that.
My point is that they'll always diminish in value because the indigent care increases year after year.
So are we assuming that, or is that factual?
I think that's.
I don't know.
think
Is that
that's
factual?
Kind of the trend. I feel like from my local
factual?
hospitals.
Well, then if that's factual, then that argues the point of maybe if we're going to do a 36-month window, maybe we need to take that into account, what the trend line would be. In other words, if we assume that there's going to
Right.
be,
That's right.
Forgive me, guys, is it 6% increase, 4%, whatever that is, we have to factor that in before we make the allocation. Because the worst thing we could do is allocate into a short position or allocate into a long position, which means we constrict the market, or we make it where everyone has
So if
nothing
you
to
are
sell.
going to do a 3-year window or whatever year window, that you do have to take into account the value that could come up the third year or the number that could increase.
Based on the head nodding out in the audience, yes, it would seem to be everyone's in violent agreement that it goes up. So we would have to take that into account as we release the allocation.
Yeah.
This is a lot of fun, isn't it? Are you confused? Okay. All right. So let's move on to the next slide. Okay. This is the impact. Is there anything else? I won't read this to everybody. Is there anything else that people see as an impact to this particular conversation? In other words, does this do anything else?
I think the only, if I could, thanks. The only I would say, just to, so we're all looking at it the same way, or at least how I'm trying to look at it in my head, is when I think about the greater access to services, that's that aspect of geographic disparities. That's what really, that's what's interesting to me about our discussion, is this concept of the provision of charity care and the access that individuals have to that care is not evenly distributed across the state. Man, that's the societal good that we're actually trying to fix here through through this type of approach. So maybe it's just a concept of, as we think about, unless there's other aspects of it.
No, please.
But when we think about the access, it's that connection point to the geographic disparity. It's not just some amorphous concept of access.
I see what you're saying.
And I don't,
So,
it just
no,
may just
that's
be from
good.
a clarity and specificity perspective of
Yep.
of what we mean by this is going to be better for patients and their access to services,
Mm-hmm.
is because those organizations that have more demand and more burden will have more resources to expand their ability to take care of those patients, which will add access.
I'm going to go ahead and I want to, because this is, like I said at the beginning, Dane, this doc will keep changing. I want to add that if that's okay with you. I'm gonna call that the Dane clause.
Hey, there you go.
Okay, anyone else? Because again, this is something that's gonna be viewed by people. Okay, next. All right, the design of the system, we can skip the placeholder if you don't mind. So if we could, oh, thank you very much, David. You're keeping up?
Yep.
No, love it. All right. This was I hate to say simplistic, but this was essentially, if you're looking at the floor and you'll see on the left side, Hospital A is fully above the floor, Hospital B is not. I probably think pictorially, and David pointed this out, we should probably move those 4 boxes on the right where the 2 that are blank should go below the floor, so it's clear that they've missed it. So I'm sorry, so from a picture point of view, the graph needs to change. But ultimately, we know now, based on this picture, that we would see that A would sell B basically 2 of those units, and it would go through the trust fund so that we could catch the match. Okay, does everyone understand? That's like the general idea. Next one. We already talked about the key decisions, but I'll go ahead and we'll put it up just so that everyone can see. Setting the thresholds, eligibility for care, defining the floor, determining whether or not it's DRG, CPT. We still need to figure out the outpatient one, and forgive me, I am not the expert on that one, but we do need to figure out how do we normalize that. Creating the exchange, the governance, the oversight body, I think that there's very, very key. And what I mean by the oversight body there, guys, is, and again, when I say this, I'm not trying to create a government entity, so everyone, what we want in a perfect world is a body that's able to see how the trades are going to make sure there's nothing, frankly, untoward about the trades. No different than in a perfect world, the SEC making sure that there's no insider trading. All right, next. Oh, wait, hold on. I flipped the wrong way. Oh, should we go back to which slide? Which slide number?
This one, the key. Either one, the key or the one before.
Okay.
Okay, I'm still looking at the 2. We've got the $10 billion in the House where the money is. That's where it is, right? $10 billion or what?
Oh, you're talking about the black,
Yeah.
okay.
Okay, that's the
floor.
The floor.
No, so the floor would be the line.
Okay,
So
floor
see
is
the
the
line?
line. Okay,
That
there's the
horizontal
line.
line? Yep.
And Hospital A
Mm-hmm.
has extra.
Yep,
They got 3 extras. And they're going to sell them?
correct.
Who are they selling them to?
People who are below the floor.
No, they're
Oh.
selling the people. They're selling the patients.
No.
The cost. Okay, what are they selling?
So the unit.
The unit?
Yes, so let me, okay, no, this is good.
This is good.
No,
Yeah,
this
I
is
need-
good.
I need to understand. the
Let's
flow.
assume for a moment the floor, again, just for math purposes, it isn't 10 billion, but for math purposes, we're using gross dollars, and it's 10 billion.
Just
Okay.
for numbers.
We make the decision, and again, I don't want to limit your issue about it goes up. So let's just make this really
Just say-
simple.
just
Okay.
very simple.
So 10 billion. We decide we're going to release 100 million units, tradable units, like a stock.
Yeah.
Think a stock
How many
or a unit of
stocks
currency.
there are.
How many stocks there's? 100 million.
And
Okay.
what does the stock represent?
The stock represents, well, that would represent 100 million times 100 would be times 1,000 would be 10 billion. So that represents $1,000 of whatever normalized dollar amount.
Services
Call
that
it
hospital-
DRG just for the purposes of the
For
conversation.
DRG. It
1,000,
doesn't matter if it's 1 encounter or 50 at a hospital.
exactly,
It'll be the dollar
through
they-
that normalized unit.
that
That's
they
right.
spent on uncompensated
On
care or
Charity care.
charity care.
Exactly.
Okay.
So we hand them, and I want to stand up, sorry. So we are going to hand Emory, let's just assume for a moment, $1 million. So that would be 1,000 divided into $1 million would be another 1,000. So we're going to hand Emory 1,000. So now they're holding on to currency. Technically, I know you're not going to. Emory could fold that very day and just sell those 1,000 and just keep that money. Now that would be insanity, but the point being is there's value. We've just handed them currency like the US dollar
And we handed it to them
because we know from last year or some baseline, and that was what Teresa and I were discussing
Right.
about 30 minutes ago.
have proven
We know
that they had
that
that
they've
in-
proven that in the past they did $1 million of charitable care. So we're going to give them the $1 million right now. So here it is. So Dane takes it from me. So he's holding on to $1 million of currency. Think of it like a bearer bond. Okay. So now we're going to true up at the end of the year, and I don't know if you want to pick Dane as the A or the B, but either way,
Okay, let's go to Hospital B. They need some.
they need some.
They're the.
And let's
on the other
assume
side of the
he's
cafeteria.
hospital A and he was over the floor. So now at that point, then we know in the beginning of the year they were marked at $1,000, quote, a unit. And again, not to a patient, that's an aggregate number.
Okay.
Dane then decides, and again, I'm assuming he and his CFO will do this, or maybe the board does. That's their decision on how they want to govern it. But they decide that when the hospital that's under the floor calls up and needs it, the price is going to be $1,100 maybe, or maybe it's $900. Again, that's going to be something that they're going to have to do as an arm length transaction. And then they sell it, and now, just like a stock registry, they will report it to the governance committee, or the governance, and saying stock certificate A and stock certificate B was transferred to hospital B. So now we know,
Hospital B is a poor little country hospital.
oh, well, no, then they're not going to be under the floor. They'll be over the floor.
Okay, so it's a big city.
Big city,
well-to-do
right,
hospital.
yeah.
Okay, and they're gonna say, okay, we'll buy yours, you know.
Right.
How's that gonna work?
Right. So there's going to be an arm's length transaction, and then at that point, then the group that's under the floor will purchase from Emory 2 of those units, whatever they decide is a fair number, and then on April 30th of the following year, when they have to quote report, they're going to quote hand back that currency. So I'm going to hand out my hand. Let's assume I'm the state of Georgia. Dane's going to hand me back. You know, I handed him 1,000 units at the beginning of the year. He's going to hand me back those 1,000, or he's going to find a way to, because he has to, or he's not at the floor. If he hands me back 900, that's a problem. Now he won't hand me 1,100 because he's going to hold the extra 100 for next year. He's either banking them to help Emory, or he thinks next year they're going to be more valuable, which is all those are decisions each hospital will make. And then next year he can sell them, or maybe he'll hold them to the following year. Again, that's his decision. But we need to retire them every 2, 3, 4 years, so we start all over, because they're not going to bank out for 10 years, for instance. It's not like IBM.
Okay.
Did that help?
Yes, because
Okay.
that was one of the things I saw. This could really turn ugly.
Yes, it could. And ugly, and not in a necessarily a nefarious way, but it could turn ugly in terms of an accounting thing. And again, we're not trying to cause the CFOs of the world like Teresa. We don't want her head to blow up. So we need to make it straightforward, a framework, and we definitely need to make it where there's a time certain, like
It's gotta
24,
be
36, or 48
equitable.
months.
It's gotta be
Has to be equitable.
But regardless, there's gonna be winners and losers among
Yes.
the hospitals.
Well,
Yes.
I'll take slight umbrage with the definition of winners and losers, and I don't mean to be splitting hairs, but
Okay.
it all depends on if the overall goal is we need to find a way without the government telling us how to do it. And again, going back to the football metaphor, you guys figure it out. You're smarter than us when it comes to, quote, the delivery of care. At that point, then I think the winner is, I'd like to think it's all of you. Because now we're not in your hair in terms of how to do it, when to do it, and what to do. We're just saying this is what needs to get done, and do it as efficiently and innovatively as possible.
Hospital in Cuthbert doing this. The caliber
Wait,
of the board.
Rep Green? Or,
You want, no, he's fine.
okay. All right, can we move on, Representative? Oh, do we need a bio break? Are we okay? All right. Design. We talked about slide. No, hold on. I'm flipped around. Sorry, my apologies. Slide 11. Key decision points expanded. I don't necessarily think. I think we've hit everything here, guys. Please take the second to read and let me know if you think we haven't. Are we good?
Yeah, I mean, just for completeness, in addition to the questions we've already asked about these terms.
Oh,
Right,
yeah.
because we said DRGs are inpatient, there's outpatient, all that kind of good stuff, so just.
Yeah, we're gonna add to
Yeah,
this.
we've had lots of discussion around.
Yep.
How to broaden these out.
Yeah, and we need to.
Yep.
Yeah.
Great.
Remember diagnostic places, that's another, it's an outpatient, you may go just for an outpatient lab test at a hospital, and you've got to include that as, it's a different code,
Teresa, is that?
right? They need to make sure that they consider things if you have a mobile mammogram or a
It's
CT?
outpatient.
It
Yeah,
is?
I mean,
Okay,
it's either outpatient or it's inpatient.
okay,
Okay.
all right,
It's
So
one or
is-
the other.
okay. And that's fine, because
Yeah.
before we had talked about specifically surgery, if it's an outpatient surgery, or if
It's
it's just
outpatient,
an
right.
outpatient, or an
And
ER.
those are all billed, and I just go back to standard, which is Medicare.
Okay.
You either bill it Medicare inpatient or you bill it Medicare outpatient,
Okay.
regardless of where the service is. Ambulatory surgery center, clinic, diagnostic center, whatever.
Does that make sense, Rep.
But
Taylor?
they don't always adjudicate it that way.
Wait, that's pretty important.
just
Well,
had
what do you
one
mean
patient
they don't
that-
adjudicate it?
I had an inpatient that they coded as outpatient because it was observation. They do.
Observation is outpatient. It didn't meet criteria for inpatient.
Right.
So Medicare will pay it as outpatient.
Yeah.
It has to meet medical necessity
okay.
to be inpatient, so observation is outpatient.
But for clarity, if you're covered, if you're an entity that's inside the system, whether or not you're out or in,
Right.
it's part of this. Okay, all right, okay. No, please.
So, for this discussion purposes, an ER visit, if you put in an ER visit versus inpatient versus outpatient,
An ER visit is an outpatient visit.
right. But for this, currently, but for this purpose, should we be thinking about that? If you're looking at uncompensated care, where is the critical point for uncompensated care? Is that ER? Probably so. Should there be a bucket for ER? You see what I'm?
Or office visit clinic.
I think we should, I have to make it more simple.
Mhm.
Regardless if it's inpatient or outpatient,
Mhm.
we determine the cost of the care to the charity or the indigent patient.
So I agree.
That's the way to do it.
I agree, with one little caveat. Is it helpful for us to start getting a cleaner view of what's impacting us more significantly from a category standpoint?
We probably already have that information as a starting point on your hospital financial survey of what you have classified as charity inpatient and charity outpatient. You probably have that as a starting point.
Yeah. I just know when I travel, what I hear is ER. ER,
Right.
ER, ER, ER. And I just wonder whether
Because that's primary care for these people we're
Right,
talking about.
exactly.
That's how they,
And that's my-
how
and
they
that's-
obtain
that's
their
my
healthcare.
point.
So
That's
if
my point.
if I may, what I'm hoping, Commissioner, is to the point Teresa made, just make it simple, put it all into one. My hope is that framework, this framework, will incent the players to, if
Start
ER is what's killing them, which I know it is, by the way, then they'll figure out ways to not have it kill them anymore. Everyone's going to want to try to find the most efficient way to get to the floor, right? I mean, at the end of the day, that's what we're going to incent them to do. So I hope, to your point, yeah, they're looking at every dollar to
Right.
see where it's happening. And you know what? Is there a way? And I believe Grady, for instance, now, before you walk into the ER, I guess there's an opportunity to walk into the clinic.
Be diverted.
Right, be diverted. So again, I'm not going to say everyone should do the Grady model. That's Grady's answer. But at the end of the day, I do think we need to keep, not forcing, I hate to use that verb, but incenting that type of behavior. Does that work?
And many of
Okay.
our facilities now have urgent care centers. There may not be clinics, but they're urgent care centers where you have an opportunity not to receive that higher level of care in the ER.
And I think we need to identify that. And that should be a goal, to divert as much care as possible to the clinics as opposed to an outpatient.
But Rep. Taylor, I'm thinking the framework that we create should incent the players to do that. In other words,
How
I
do we
don't want to
measure if it's-
prescribe to
How
them
do we measure if it's working, if it's doing it, if we don't identify it?
the floor.
No, the floor will do dollar-wise, but you won't know if those encounters were in or outpatient or clinic. You'll know if they're in or out, but you won't know, was it at the ER, was it a clinic walk-in, or was it an outpatient surgery? You won't know. Does it make a difference? Do you care?
No.
But how do you know if it's working, that they're moving people to the outpatient clinic as opposed to or you don't care?
I do not. In my mind, we've said we're incenting you to be efficient. We're incenting you, when it comes to the care of this strata of individuals, we are going to assume you will do the most cost-effective, efficient, effective measures to make sure they're taken care of. And if they want to keep doing it through the ER, I'm not going to tell them,
We're gonna
well, we're not paying.
Well, the floor will keep them.
Well, no, but the normalization will disincent behavior to move them into the ER constantly. And if it doesn't, then we need to look at the model, but
Right, I think that we're hoping for this efficiencies.
sure.
But, not to be funny, if you
No,
look at the
please.
dollars, if you do the ER instead of the clinic, it's gonna cost you more.
But correct me if I'm, and sorry, CFO, keep getting questions. This,
Does that make sense?
is the ER, I know you guys charge more for the ER than you do the urgent care.
Yeah, because we have surgeons and everyone waiting for
Everybody's
you
there.
at the
Right, no,
doorstep
I
to get there.
completely understand. So to Representative Taylor's point, if you just loaded everyone into the ER, would you abnormally reach the floor faster?
Yes.
It's a great
You
point
have
that
to.
Rep Taylor's making.
You have to.
No, I don't know. Is that a correct statement? So even if we had a normalization,
I know.
so that's a perverse incentive. So we need to solve that then.
You've got to be able to identify, so you can see, this year we had 1,000 encounters in the ER. Next year, it was down to 800 because we sent them to the clinic. We knew it would be more effective. But you've got to be able to see and prove that you've been doing it.
But is there a way to do it through a normalization? In other words, I don't want to tell anyone how to run their business because I don't know anything about running Emory. But I do
I'm
know,
telling them, but I want them to prove to me they've done it and it's working.
right, but can't we, I'm just asking the question. So you raise an amazing point. It's a great point. Can we do it through some normalization of the unit as opposed to me deciphering whether or not Emory's moving too many people into ER or not?
I don't want them to rewrite coding and how you do it. Is there a way you're already
Can't,
capturing?
that's federally regulated.
Right,
Right,
exactly.
That's what I mean.
Right, yeah,
So it's
so-
already done.
Right.
Coding, so we're not changing that, but is there a way to identify it?
Well, is there a way, and again, please don't take this as literal as it's going to sound, is there a way to take every ER code and only multiply it by 0.6? I'm just asking the question. In other words, I'm trying to make it where a cough diagnosed in the ER and a cough diagnosed in the urgent care, they both get you $100 of charitable credit as opposed to one getting you $400 of charitable credit and one getting you $100. That's effectively what you're
That's my
saying,
point.
right? I'm just asking the question. You guys are like, I never should have agreed to be on this committee.
Well, I think what I think what's interesting is this
Yeah.
actually harkens back to, and I forget who mentioned it, is the idea, is there a way to get preventive care valued in a different way? And I
Yes.
forget if it was.
That was you.
Commissioner, okay, yep, thanks. So, I just forgot if it was Commissioner. And this is what we're talking about, is because I do think it's a situation, now there are some aspects around the way that hospitals use compliance, meaning I don't think there's as much of a risk of an emergency medicine patient getting an inpatient stay, to spend more money on them. I think we
No,
have
that doesn't
compliance, I think we have some compliance aspects that will reduce that risk. But this aspect of investing in urgent care to be able to reduce the impact, there is a perverse incentive here that was brought up on the idea of somehow valuing preventive care, or even maybe not preventive care, valuing less expensive locations of care, maybe a way to even broaden it out.
Maybe by place of service.
So for instance, if Emory was to hypothetically make an investment into Cordeal, I don't think you have a facility in Cordeal. That's obviously a lesser cost in terms of land and things like that. Is that what you're referring to?
I actually was just thinking even more closely on the idea of an urgent care center
Versus
across
an
the street.
Oh,
from
I see what
ER.
you're saying. Okay. Oh, I see what you're saying. Okay.
Or even
All right.
opening a primary care facility open until 11 o'clock at night.
Right.
It's those kind of.
Got it.
I was thinking
Okay.
even more narrowly than that.
Okay, got it. Okay, thanks.
Yeah.
Is that Representative Tarvin?
Just from somebody that's been on the paying end of all this, that made a little more sense. But I guess how does who controls currently who goes to the ER?
No one does.
one.
No one.
I don't think
It's
any
It's
should.
the patient.
Okay, but my point
And
is,
it's
what
very
can we
difficult to
do?
direct patients to direct patients, especially in the population that we're talking about, to seek care at an urgent care center, because an urgent care center is going to ask you for financial, from money. They can do that, they're not regulated by EMTALA. So the indigent and the charity care patient is going to seek care because they have no money in your ER setting.
Okay.
And there's 4 levels of ER care. And we do a very efficient job of triaging those that are just a cough or an earache at the very beginning, and they see a mid-level, and they don't incur a lot of cost.
Yeah, my question maybe was a little too facetious. We're talking about control. We're not trying to say how we get people to go to outpatient clinic other than emergency. We can't. Because they don't care. I mean, I don't mean this to be mean. They don't care. If they did, somebody like me would take better care of themselves. They've got insurance, they hadn't. How do you incentivize a person that doesn't, I don't mean this, I'm not trying to be mean, but a person that doesn't take care of themselves, maybe somebody who, and I've been in this position, can't pay their bill. How do you incentivize them to go to outpatient care instead of emergency room?
And they won't, because they are going to be asked for money at an urgent care setting rather than an ER.
They're going to be asked to pay that day?
Yes.
Okay. So they're not, they're going to go to emergency room.
Teresa, you said an acronym I'm not familiar with. You said urgent care isn't under, what is it?
It's not regulated by EMTALA.
Oh, EMTALA. Okay, thank you. Okay. Sorry. Thank you.
I just, you know, as we discussed, it was almost like I was trying to get the doctors and hospitals to come up with I know what we're working forward, but how they could do it, I don't have any idea how a hospital or doctor could drive somebody not to go to the ER.
So who do we think would be a source of expertise to help us with a normalized unit? We've heard an inpatient, outpatient. We've heard the ambulatory surgical care. And now we have what I'm going to call the ER multiplier, which a perverse incentive could be to literally send everyone into the ER to meet your floor faster. And we don't want that. So anyone that we know within our Rolodex, Ethan, do you know anybody? Sorry, I don't mean to put you on the spot. Who
We'll look into it.
but do you understand the question?
I think that, yeah.
Dane and I, or Teresa and you guys, I don't care who, if you could discuss it, because we need someone to help us normalize this. If not, Rep. Taylor's point. What? Oh, yeah.
I understand what your question is, and I understand the concept. I think what I'm getting lost at is the federal law requires a hospital to charge every patient the same. Not every hospital has to charge the same thing. But I'm Hospital A. I have to charge, I don't care if you're commercial insured, Medicare, Medicaid, uninsured. The charge is the same. Uninsured, we're getting, call it zero. Sometimes we get some payment if you go through a collections process. Medicare, you get 85% of costs. Medicaid, I'm sorry, I'm doing that backwards. Medicaid, 85%. Medicare, 95%. Commercial insurance, it's whatever you negotiate from patient to patient, plan to plan, procedure to procedure. I think to normalize that, I guess the best basis is going to be on Medicare rates.
Care?
Medicare, federal, and use DRGs or CPT codes, normalize it with that. But again, in the setting, those are the charges, those are the reimbursement, but the costs vary so greatly from facility to facility, community to community, department to department. I totally get the concept you're trying to do, but I think now that we've flipped it to floor and trade and we're talking about all these different factors that go into it, that's where I'm getting lost. And I guess what I really want to say is I'd like to see the model and see historic numbers run through the model to see how it would work. And beyond that, I'm getting lost in some of the overwhelming details about how this would work.
This is our first work session.
Yeah.
So no, it's expected. No, all of us, I think, are kind of swimming in a sea of, oh my gosh. And Dane right now is wanting to retract what he asked for in October when he said, I really want to sit down and get more information.
One of the other questions I guess I had, if it's okay to ask this question, Mr. Chairman, is the goal indigent care or is it uncompensated care? Because I hear those terms being used back and forth. And there are many, many factors, again, that go into uncompensated care.
Right.
And depending upon what facility you are, a small rural hospital or a large system in a metro area, there are different factors that go into what your uncompensated care is.
Mm-hmm.
Is it high Medicare, high Medicaid, low commercial insurance? So that's where the details are finite, really, in my opinion.
So let me answer that. The initial intent, and I'm not trying to tell the committee that just because it was my initial intent doesn't mean it has to remain the intent. The initial intent was charitable and indigent care. It wasn't uncompensated. I do think there is a close relationship between the two, but I don't necessarily consider them to be an R, going back to our college stats class of 1. I don't know if the R is 0.9, but I definitely believe it to be closely related. So I think that's why sometimes you'll hear some of the novices, meaning those of us who are in the General Assembly, sometimes using it interchangeably. But right now, it really is meant to be charitable and indigent care, just for the record. Now, going back to the first comment, Ethan, if the GHA would be so kind as to look inside of its 170 member group you have, and then the access to the experts that you have, the normalization, the unit normalization, to me, if it's not the most important part of this, it's in the top 3. And because of the fact it's the unit, it's how we are defining it, we get to define it. In other words, we're not held to the feds. So hypothetically, may it be at Medicare at 95 or Medicaid at 85, et cetera, we could always say, and I know DRG doesn't cover everything, but let me just use it, just go with me for a moment. The unit is DRG times 1.1. That's the unit. So if the DRG for that particular, and again, I don't pretend to know all the codes, but for that particular procedure is 100, well, it's 110 then. And the reason we did that is we looked around and we tried to account for all those variables you just said. Is it metro? Is it rural? Department? Blah, 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 blah. And the best way that we could do it through one unit is we said DRG times 1.1. Or CPT times 1.1. And again, I'm not trying to put answers into anyone's mind. I'm just saying, let's not be confined to today's world. Let's be saying what works the best for this framework. And I think we do have that latitude because we're not asking the feds to do anything here. So we do have a lot more latitude than, quote, we normally do here at the General Assembly in terms of what we can do with medical care.
I think it would help to answer that question is to really see maybe a first draft of how the formula would work. And then if it's the normalization of the unit, figure out what factors have to go into that. And
so could I ask one more favor of the GHA to consider? We are in dire need of a data scientist for about 3 or 4 weeks. Is there anyone on staff at any hospital? And I know everyone's like, we're all short-staffed. The challenge is we can't get anyone to help us with a true data model. I mean, one that everyone would say the efficacy can't be questioned. It took real data, it poured it through, but I think we're in dire need of that. So if that's something that you guys within your Rolodex across the state have access to that individual, I'm happy to literally drive to that person or fly to that person to walk them through it or get on a WebEx, a video conference, but anything they could do to help the committee, we would appreciate.
Yeah, I'll certainly look into that.
So 2 things, the code and then the data scientist.
Yes, sir.
Great.
Thank you.
Thank you. We never knew we could have so much fun. All right. So I think what I want to do, if it's okay with everybody, I'm going to skip very quickly. I'm not going to go to page 14 because we're going to go to the model momentarily. I think page 15, we already talked about that a bit. So I think that gets an understanding of what that transaction looks like. Page 16, I think same thing in terms of what the transaction could possibly look like. Page 17, this just gives it a bit more in terms of having a couple who are under and one that is over. Page 18 talks through all the transactions that are going to go through the exchange, and that's a lot of fun. Page 19 talks about what the transaction could be through the exchange, and at this point, I think Emery's going to ask to be taken off of any slides, and it wasn't meant to be picking on anyone there. You know that. And then finally, on page 20, in terms of what scenario could be like in year 3, in terms of what the exchange would look like versus a bilateral contract. Oh, page 17? Yes, sir. Hold on. Hold on.
That hit me, there was some errors there, and
Oh,
I said it was 120 altogether, and I kind of understand what happened. And
you know what? You make a great point, Representative Tarvin. We'll put in...
Usually if I ever think of anything, it's a pretty good point.
Yeah. So we'll add in here that this was a bilateral contract as opposed to being in the exchange, and then we'll also add in arrows. So then that way we can see the directions of the dollar. So it was a bilateral contract. Nope, I get it. Okay, no, that's a good catch because the next slide goes through what it would look like in the exchange. Okay.
Mr. Chairman, is it the intent of the committee to do a pilot program or do we just go for the whole thing with all the hospitals?
The intent is to do the whole thing, but understanding that before we kick it off, again, I'll just use years here. We say it's effective, and I don't know if we'll go fiscal year or calendar year, but say we go calendar year. It's effective January 1st, 2022, when the pilot year would start, all the way through December 31st, 2022. Then we would have like a 6-month break to basically allow this committee to come back and say, what did we learn? What didn't we learn? What was good? What was bad? Have all the players. So say, for instance, we only covered nonprofits. Have the nonprofits come to us and tell us, what did you like? What didn't you like? What we're going to talk to the rural governments to find out what happened, what didn't happen, and then refine the framework and then let it launch, July 1 of 2023. Again, I'm just making up things, but that's what the intent is, Representative Green.
Okay.
Representative Tarvin.
And just, since we're talking about 2022 and got 3 weeks to talk about this, I understood what you were saying. Quickly, what's the pilot program? Quickly, don't go into too much detail. Pilot program lasts 1 year. Who would be in the pilot program?
It would literally be what we want. Say
we would pick the people out to do it.
No, everyone would be. So if we said all nonprofits and only nonprofits, it's only the nonprofits in the whole state.
So we're going to set a model for the whole state for a pilot program.
And let them use monopoly money instead of, quote, real money.
Okay.
Yes.
Okay.
No, but we want them.
Okay.
We want to give them the allocation. We want them to retire.
What the outcome would be
We want them to do everything
without real money.
without real money. Even ask whoever we're going to ask to oversee it here in Georgia, oversee it with them, do everything as if it was real. The only thing that's different is it was monopoly money and not U.S. currency.
And we feel like it would be beneficial enough to everybody in the future that they would cooperate or really keep up with this. Or
I'm not going to speak for them, but I will say that what I saw in Cap and Trade, they did this, and every executive team I spoke with and board I spoke with, and these are multi-billion euro companies, every one of them said the same thing.
Excellent.
Thank God we had the year to understand how this works.
That's good.
So I believe many of the executive teams of our hospitals would appreciate a year to understand how to do this without there being a penalty or anything like that.
Do we
Representative Taylor?
have someone in Georgia, it goes back to who is going to be in charge of this charity care exchange? Do we have someone here in Georgia, or is somebody doing this now somewheres?
Hypothetically, it could be the person to the right of Representative Fry, but I don't know. I'll let the committee decide that, and right now he's running, so
Close the door.
close the door. He's like, not after this conversation. I don't want this responsibility.
A question for Commissioner Berry. In that pilot phase, do you think we could also understand the impact of the matching with the ICTF? We probably could. I'm more hoping than guessing, because I'm trying to figure out if potentially I don't know if this is, because I don't know how all the mechanisms, and I'm sure you do it a lot better than I do, is if there is a way that this could, like, is there a possible way of raising all boats and potentially reducing some of the risk of an organization having a really bad outcome? And maybe we can, again, that's the whole idea of the pilot, but I wonder if there's a way, like within the pilot, that we actually pilot the whole project with the monopoly money, but in a way that actually understands the impact of the Indigent Care Trust Fund and the mechanism of that.
So,
Overlay it.
yeah, so I think that this is similar. It's a totally different scenario.
Mm-hmm.
But for instance, when you moved from grant and aid to fee for service for the public mental health system, we had a year's overlap so
Okay.
that nobody was harmed
Yep.
during that first year. It was monopoly money,
Mhm.
and you could see who was going to come out based on population, based on number of units delivered and everything else. And that helped us inform how those formulas would work. Because the last thing that we could take a chance on doing was harming up the public safety net, which to me, this is a similar situation
is.
of potential harm, not because of this, but just because of the whole discussion. Whether that's Indigent Charity Care Trust Fund or whether that's this, you definitely do not want to take a chance on harming anybody. And maybe the first year, if this were to move forward, you would do the hold harmless, and then that would help determine your first year implementation formulas that would go into. Does that make sense?
It does, thank you.
Representative Fry?
Thank you, Mr. Chair. So I think that's a great question, and I asked about the match last meeting and kind of received a circuitous answer. Maybe you can help me with that. Is there more room for us within the Indigent Care Trust Fund to increase our federal drawdown?
I don't know the answer to that. We'll look into it.
Because I think some matches, they'll have a cap, so you can do X amount and we'll give you up to Y. And so, because that would also provide an extra benefit. So if we have a greater fund in the Indigent Care Trust Fund, then we could draw down more.
That was my question. Is there
I'll
a
check.
way to use that to leverage?
That's right.
I won't call it a waiver, but it's some way to use that.
And I also think it will be important, from my lens, and I certainly recognize I'm not the sharpest tack in the box in here. What are we trying to fix from the Indigent Care Trust Fund? Very concretely, that this will fix. What's broken about that this will remedy? And I think we're going to need to have some.
Is that a rhetorical or
No.
is that a question?
No.
That's a
Oh, okay, I wasn't sure.
Yeah.
Okay.
Um,
Yeah, I can answer that.
I think we're going to need to have some real concrete white papers, one-pagers, whatever we want to call it. We're talking about it, but there's a lot of people, including me, who will need more guidance on it. Yeah.
Okay. And you think we should put together a one-pager on that? I'm just,
Take two.
It might take two. I mean, I just think that we need to be able to very clearly describe what we think is broken.
sure.
Because I think the questions are they're going to get asked. One question that will be asked is, can you fix a current situation? Do you want to throw it totally out? I don't have, I follow what you all put in legislation and the governor signs. So I don't, that's my job. But what is it that's broken? Is there a way to repair it? Or is the repair to replace with this?
Or,
And
I'm sorry.
go ahead, no.
But there's a fourth option
Okay.
in terms of working in concert.
Yeah.
Yeah.
Supplement.
Okay. I exactly. I
Or
don't
do you
want,
keep both?
Exactly. I don't want this to be seen as a replacement, but
Yeah.
rather, how can we, working in concert, create a framework that allows the stakeholders to actually implement?
Yeah.
Okay. Representative Fry?
No, I think that's a great point. So the other option is to raise that 3% to 6%. and let the government tell everybody what to do, right? And then this is a way that you're going to be able to take your own initiative as organizations and figure it out on your own, but still increase the availability of the care and the flow of the funding to the different hospitals that need it. Is that kind of a pretty,
I think that's close.
yeah,
Okay. I don't think that was poorly worded.
just going off of how I know you.
So,
You didn't get the joke, did you?
No, I got you.
You got the
I
joke,
got the
okay.
joke.
All
I'm
right.
Chairman
sensitive
Jones,
about it still.
do we also want to model all of the hospitals, not just nonprofits, once we've established the floor there to make sure that there's not a disadvantage? Because the for-profits could be way above the floor in providing the charity care.
I had that same thought.
Yeah,
I'd like to see their numbers.
If we're fortunate enough to get a data scientist, in my opinion, let's throw the entire kitchen sink in. I mean, I'm talking every acronym we know, ASC, for-profit, urgent care, you name it. If it's part of the acronym alphabet, move it in, let it get through the model.
Include the government the hospitals as
Yes,
well.
include oh yeah, absolutely. I'm not
Okay.
looking to, no one gets Kevlar on this one.
Okay.
It runs through the model, everyone runs through, and then at least that way we're making an informed decision. Yeah. Yeah, I don't want to play favorites, and I definitely don't want to tip the scales for anybody. Let's just go full-on Roman Colosseum. All right. I have to always get in a gladiator metaphor, if you don't mind. Yeah, it's good to do. Is it something about the gladiator?
The bad part about this is,
What's that?
I understand and appreciate your sense of humor, and that bothers me.
Thank you, Representative Tarvin. Okay, can we move to the rudimentary model?
Yep.
Okay, yeah. Actually, can you just put it up, please? Look, everyone, this is about as rudimentary as it comes. I mean, it's a spreadsheet, okay? So by no means, I don't want anyone's hopes to be dashed, and I don't want them to be turned up. I think for the purpose of a microphone, I need to stay here because I wanted to get up there and talk. Do we have a pointer? Yeah. We do? Okay, if I could use the pointer when you're done. Okay, all right. Oh my gosh. Can we ask Chairman England for an appropriation of a new projector and screen? Okay. All right, well then, hold on. Sorry for. Oh boy, that's too much. Yeah. Just right there for a second. All right. I'll email this to everyone, and if you're interested in the audience, I'm happy to email it to you. But what we did was, down the left side is every nonprofit. So that goes down, and Dave, remind me, maybe 200, 300 rows. And that's column A. Column B, I think self-explanatory, city. Column C was staff beds, total discharges in column D, patient days in column echo. Gross patient revenue, and again, I want to stress, this is a proxy. No one is thinking we should use gross patient revenue as a calculation for the floor. But we don't have all of the normalized numbers, so we use gross patient revenue, okay? I mean, I know you guys aren't surprised, but certain ones of these are pretty big numbers. And then we said the target for charitable care, okay? And if you click on that real quick, please, David, that formula, okay? So you'll see the target for charitable care was defined as the gross patient revenue multiplied, and we just put 7%. If we want to model something different, we can. But again, this was just, I don't want everyone to get wrapped around the axle. Can you move to the right a little bit, please? Thank you. Then what we did was we took a random number generator. So for instance, if you go down here, you'll see Grady, I think, is actually in a surplus. I think a deficit. I think we can all agree Grady is not in a deficit for charitable care. But again, we took a random number generator assigned between -1 and 1. This way because we didn't know all of you, all X hundreds of nonprofits, where you were. So we didn't want to cause anyone to see their name and then they go, well, that's not where we're at. You know what I mean? And then that kind of creates an efficacy issue. So we're just saying random number, and we literally started to put random numbers against this if you were up or if you were down. That then caused a charitable care gap, which means you were below, or a charitable care surplus. Red means you're below, black means you're there. David, if you could scroll to the bottom where the sum's at, please. Thank you. Coincidentally, the amount of charitable care that needs to be produced based on this model is 7.1 billion. Remember, we put it at 7%. So again, I want to make sure that you guys understand we had it about 100 billion in gross dollars, 7 billion, and then what we could do is we started to go down, and why don't we go to Grady just because it's the one that we talked about probably more than anyone. Can we go to Grady, please? Where's Memorial? 39? 39? Okay, thank you. Okay, so we know these are accurate numbers, the gross numbers, okay, of about 5.5 billion. But again, you'll see here, their charitable floor would have been 383 million. Keep going to the right, please. The random number generator said that they had a surplus of only 8%, which we all know not to be the case. So they were only sitting on around $31,000 of units that they could trade into the system. So as you look at this model, what we were trying to give you guys was a sense of, okay, I'm Grady, or wherever you want to go at, I have someone who's below here at 1,400, I got another one below at 4,000, but I got one right here who's in surplus of 136. So the natural thing to do during the time, the first 2 years before the exchange, is going to be, we want to be able to provide everyone with where we expect you to be at, and then you'll know to call up someone in Representative Green's district or someone in Representative Taylor's district, and most of the time that's going to be coming from someone in my district in terms of that phone call asking to buy, because we don't have hospitals that we most likely will be, quote, above the floor. So I think at the end of the day, what we can be saying is this is one way, again, gross dollars not being the correct way, but it's one way with a proxy to just take a look at how this could move within the market through bilateral contracts before we could get into the part where we have an exchange. So I'll stop there. I know because of the streaming, they're probably wondering what we're saying, but at the end of the day, is there anything that I could answer specifically why I'm still here? No questions?
Where did this data come from, sir?
So if you go, oh, sorry, David, can you go back, please? Click on the hyperlink, please. Like click on Grady's hyperlink if you don't mind. Go all the way to A, to alpha. Hold on. So we went out and we started to get all this data. Does that answer your question?
Yes.
Okay. We're happy to provide anyone the spreadsheet. Obviously, we're not looking. But the only thing, my only concern is, if this is going to be handed to anyone inside of your organizations, please do us the favor of letting them know this was a rudimentary draft one of proxy numbers, random number generators, not intended to be. Now, the information, can you go back to the spreadsheet, David? The information, obviously, city's accurate, and C, D, E, F, those are all accurate, actual numbers. Everything else, for instance, when you take a look at what the charitable floor is, the 7%, depending on where you put that yellow Bravo 1 cell, that's going to move your floor, but it won't move the random number generator, but it will move your surpluses and your gaps. Okay?
Thank you.
Okay, you're welcome. Anything else?
And you're gonna send us that, right?
Yeah, as a matter of fact, David or Jackie will send it out today.
I need to look at that.
Yes. No. The reason we didn't send it out first was I actually tested it on a couple of people, and it was a complete just disaster because it was, oh my gosh, I can't believe, I would never use gross revenue. No one wants to use gross revenue. Okay. And I would never do this. No one wants to do that. You know what I mean? And why did you use a random number generator? This is why. You know what I mean? So we wanted to give an explanation with context before we released it. And that's why we're asking, if you don't mind, if you do present it to someone, if you would be so kind to give some level of context, because I do think this could cause actually more issues.
My CFO's here.
Oh, okay. All right. Then you're good. Okay. All right. Okay. But Does everyone see what I'm saying? Please don't just, I think we need to share this information, but try to provide as much context as possible. Okay. Label them better?
As in imaginary numbers.
Now, we did put on top random number generator, but, okay, all right. All right. Any questions on the model other than we'll get that to you? Okay, is everyone still good for about another 30 minutes? I know no one likes the traffic, but, okay, can we hand out the bill, please? Look, everybody, Vince is over to the left of me. If you don't like it, he's the drafter. No, in all seriousness, this is only meant to be, hey, just get a reaction. It doesn't have numbers in it. It has blanks in it. Vince was really good, I feel, in terms of providing areas where we need to fill in. So do not feel as if there's not even bracketed numbers. I didn't use an old CFO tactic that my CFO uses on me all the time. Well, I'm not trying to convince you of anything, Todd, but I did put a bracketed number in, which I think is a subliminal way that CFOs work on people like me. So what we wanted to be able to do, and Vince, remind me with lead council rules, are you permitted to walk the committee at a high level through each section on what you were trying, on what we were trying to achieve? All right. It is at my discretion. Okay, so if lead council allows you to do that, if you could at a high level go through each section in terms of what we were trying to achieve. Okay. Thank you.
Sure. All right. Well, like the Chairman Jones said, this is basically just it's a very rough draft, initial draft framework, and even there are a few places. So obviously, at any point as I'm going through here, when anyone sees any issues you have, or later you go back and read it and you have, obviously this is all subject to change. So basically just went through and obviously section 1 we gave it the title, just framework to let everyone know this is just the initial step. Section 2, we just talked about some of the proposed findings that the committee could use, and that's just to let everyone know sort of the goal of what this is all about, and it addresses the mismatch that was discussed earlier, and the and then the geographic context and what this is all about. Then Section 3, we start out with the section we would use. And obviously just have a definition section where we go through, a potential definition. And all of these, even the definitions really are just, at this point, possibilities that the committee has every right to, obviously, to change. But the charity care credit, and it just addresses how that value would be computed for uncompensated indigent or charity care based on the fixed price scheduling, utilizing the Medicare diagnosis-related groups that we've discussed. Talks about the exchange, and then we have a different section that sets up that exchange, addresses the charity care floor that we've talked about, and just as the specified amount of uncompensated charity care or charity care credits that would be required of the nonprofit hospitals. And again, here, that's just an example where I think just based on previous conversations with the committee and just to have something to mention in there, I included just the nonprofits, but obviously the committee may want to expand that or not. The charity care income threshold, just based on what we discussed in the background readings that the committee discussed about the maximum allowable family income, charity care requirements, meaning the specified amount of uncompensated indigent or charity care required to be provided to indigent patients by a nonprofit hospital. So, and then again, this is the focus here is the indigent care, not the uncompensated care. So, as mentioned earlier, this would be sort of overseen by the Department of Community Health, obviously, and nonprofit hospital. The definition just came up with from language already in the code. Essentially, just combining two sections. The oversight board, as the chairman mentioned, that'd be a little bit like the SEC having an oversight board, and that's addressed coming up in a later section. Uncompensated indigent or charity care shall have the same meaning as used in the code section, and that going back to the way that it's used in Title 31, but that sort of could be something we need to could evolve obviously as well. And one note I'd mention about that too, even though Title 31 deals with certificate of need, this bill stays completely separate from the certificate of need for a variety of reasons, I think. Then Section 321 sets up a charity care exchange. And as you can see, it kind of goes through the department would be in charge then, of course, of setting up the design. So obviously, after the committee comes up with some language that y'all would like, and ultimately, hopefully, the potential would be a vote out of the legislature, then the department would still have significant responsibility in terms of promulgating some regulations to effectuate the intent of the legislature. The third paragraph there in 321, the department shall determine the value of charity care credits based on a fixed price schedule utilizing the Medicare diagnosis-related groups discussed. The charity care credits may vary based on the services provided. So that's something that we discussed earlier too, and that would obviously need to be fleshed out as well. Here, left some blanks with some items that this committee is going to need to determine, obviously, down the road. One being the department shall determine the value of the charity care income threshold to be equal to whatever the committee would like. The department shall determine the value of charity care to be blank percentage or percent of the hospital's operating cost. That's another number that the department would need direction from, obviously, from the committee and the legislature. The exchange shall be designed to adapt to market variation, and I think the chairman talked about this will be sort of done in the 3-year increments. So this language would just allow the exchange, those credits to be carried over then, I guess, 2 additional periods, so you'd be moving to 3-year periods in total. The department shall be authorized to enter into contracts with any consultants or contractors, and I think hopefully that would be helpful in a situation like this where something is so new. I would think that there would be a good chance the department would want to use outside contractors. Section 322 sets up the Charity Care Exchange Oversight Board. And then again, how these boards are set up is completely up to the committee and how y'all want to do it. I just ended up we used some language that was used previously for other kinds of boards, and this would basically just set up a committee of 9 with 3 appointed by the governor, 3 appointed by the lieutenant governor, and 3 by the speaker.
Are these compensated?
That would be entirely up to how the committee wanted to set it up. I mean, that's, yeah.
What would the representative bring, you think?
Well, I was just wondering if they are compensated for mileage and things of this nature for serving on the board.
I think we would have to.
I mean, typically there would be some of that stipend and minimal.
What's it going to cost to operate? That's going to be fiscal note I'm going to want.
Sure.
What's it going to cost to operate one? And we will have to know. They're going to have to be compensated in some way.
I was thinking whatever credit line Spencer has left on his credit card. I'm sorry.
Right. Oh, no. All right. And then this other language I think is fairly standard, but the committee, of course, may want something different. All members would serve at the pleasure of their appointing official. Any vacancy would be filled by that official, and the oversight board would select their own chairperson. Section 323, it covers the general timeline for this process that the chairman went over, with the first 2 years set up to involve the bilateral contracts that he referenced, and then on the 3rd year would be sort of the practice trading year.
That's up to the committee, but my going in position is all players would. Yeah, exactly. If not, it's hard to have a framework like this.
Got it.
Right.
All right, I just didn't see the word mandatory.
Section 324, the department then would be responsible for publishing an annual report, which would include the valuation of charity care credits purchased and sold on the exchange for each of the participants. Section 325, the department should have the authority to subject any of the participants that fail to timely meet its charity care requirements on or after January 1st, 2024, to the monetary penalty that the chairman mentioned. So up to the cost of the charity care credits owed plus 20% of that amount. But actually that, and that's something else we could talk about that more too, if that's something you want to go forward with or adjust that. And at no time would the penalty be assessed be anything less than $100. Just and the last section, 326, would need to be fleshed out some more as well. But this section would just basically deal with the Indigent Care Trust Fund, which would serve as a depository for the exchange, and any penalties collected pursuant to this section would be contributed to the Indigent Care Trust Fund. So that's sort of where we are at this point. But this is, like I said, just of course just a very rough general outline to hopefully get us started. It'll be helpful.
Thank you, Vince. Thank you, Vince. I appreciate that. Again, I want to stress what Vince just said. It was not meant to be, it's not ready to drop, obviously. What it was meant to do was just cause, thoughts. I understand this is the first time you guys are seeing it. My thought is to give everyone time to digest it, and then we can have a conversation about it. But that being stated, is there anything glaring that you'd want to share with the committee right now? Oh, hold on.
Just where it makes reference several places to a department, are we talking about the department, or are we talking about the board will make these decisions? You will inform the department of design changes, and several places it refers to department, or would that be the board?
That's reference to the department. So the department would be.
It will be a department of the exchange or the board?
Oh, no, it's the Department of Community Health.
Oh, that's what I want to make sure.
Okay,
because
yes.
The paragraph before, we were talking about the board, but all the information, everything will go through the department.
Yes, that's correct.
Thank you.
Right.
I want to make sure that was clear.
By the way, Commissioner Berry didn't know about this, so to his credit, he's just sitting there very quiet.
Thank you,
Representative
Mr. Chair. So can you describe exactly what the duties of the board might be? And are there any potential conflicts between where we have a commissioner in place to oversee this project, and what authority would the board have versus the commissioner to do his job? And that's just, how does that chain of command work? And that's something I think, probably can't fix it right now. I just want to look at, I don't know if there's any other board entity that fits within a department right now, and I could be wrong, but just to see who has the ultimate authority. Is it just an oversight board to watch and to raise concerns, or would they actually have some sort of job that they would have to do to report to the commissioner, but they're appointed by the governor and those folks? So it's just kind of we need to have a real clear description of the duties of this specific group, I think, and a chain of command.
So, would you mind if I took if there's one thing where I see this being a challenge is, let's assume for a moment the windows are 3 years. Every 3 years, a new floor is going to have to be set. And there is going to be real good arguments on holding the floor, lowering the floor, increasing the floor. Okay? The question becomes and by the way, I'm not set in stone on this. Should we let the department be the arbiter of, quote, the floor? And that to me is the biggest question that's going to always be asked.
Right.
Or do we let the policymakers affect what the floor is going to be, and frankly allow the department to be able to execute, just like Commissioner Berry said 30 minutes ago, the legislature and the governor basically direct how I run the DCH. Should we have the board take care of that policy matter is going to cause a significant amount of, let's just say, consternation. And I'm wondering, does the board handle that and then provide that information to the department? That was my thought process. That doesn't mean it's the right thought process.
Sure.
It's just a thought process.
And I think part of what we would look at is that the commissioner's department would have the access to the data that would give a better reason, i.e. the trajectory we were talking about earlier, for them to maybe to set that policy rather than it be a political policy set, that it would be a data-based decision.
I think if we do that, and again, I'm not against that.
Yeah,
If we
yeah.
do that, I think we should, in the bill, then give some general direction, to the department that the data should be X, Y, and Z, and the floor should not increase or decrease more or less than 85% of the collard against what the department has seen in the last 3 years, or something to that effect.
No, I think
so
that's
then that
important.
way, to your point, if we're going to do that to call it politics out of it, then let's just be data driven, and then I think we should prescribe a little bit more inside the bill.
Chairman?
Oh, Vince, I'm sorry.
I'm sorry. I was hoping I could just comment on that. I think that makes a lot of sense too, especially from a constitutional standpoint, because the more that the committee can come up with those sort of parameters for the department, I think the less risk the bill would run running into delegation issues.
Great point.
Thanks.
Yeah, and I think that also, again, I don't want to speak about Commissioner Berry in the third person, but I'm trying to relieve the departments of, I'll say, the decisions like that can cause a significant amount of consternation. So if we aren't going to have the board do that and we're going to have the department do that, I think let's just go ahead and give the direction inside the bill. At least that's my thought.
No, I agree.
Okay.
And can I say one more thing?
Of course.
Yeah, like I said, I think what we're really asking is trying to figure out, and I'd like to see this statistic. What's the relationship between our current indigent care spend versus the relationship of, and how is that affected with the regional aspects of it, and how is the regional aspects, how are they addressed in this legislation? Because I don't think they are. They talk about a geographic mismatch in line 17, but there's no real geographic solution to this, right? We're assuming that Gerald has a hospital that's going to have a surplus, and that Emory may want to buy them, but we're not really directing it that way. But we're addressing geographic disparity within the legislation without any geographic direction. Like, and here's another thing I thought of. Just thoughts. What if Emory invested into a company that owned 50% of Gerald's hospital, and then Emory's buying their own credits? I mean, I don't know. I'm just asking, are there any lines of that? Will this encourage consolidation where Emory says, oh, well, I can run Gerald's hospital a lot better than they're running it right now, so why don't we just buy them? And then we don't have to spend anybody. No, why don't we buy the hospital, run them more efficiently, and then you just trade indigent care credits between your two hospitals that you own?
So if I could reply to the latter, I do think there will be some M&A out of this, merger and acquisition. I do think this would drive certain corporate activity, but if we are going to judge, and I'm not going to use Emory anymore, we've been picking on Dane way too much, but if we are going to judge Hospital A as they did decide, let's say, to consolidate 2 additional hospitals out of the rural areas, well, we would judge them on, I'll say, at the parent level, not at the 10 hospitals that they own level. So if it turns out that 8 other hospitals are below the floor, but 2 are above the floor enough to bring up collectively, well, didn't we solve what we wanted to solve, which was to bring up charitable care within Georgia, even if it did mean 10 of them were underneath that one holding company?
As long as they don't shut them down because they're not profitable.
Yes.
Well,
That would be my
Yes, but
problem
that's
if they
what I'm
bought
talking
it
about.
and say, yeah, I can do this and send it 50 miles away.
send the care 50 miles away.
Yes.
Okay,
Exactly right.
We've seen
Sure.
that happen.
yeah,
Yes, we've seen that
Mhm.
multiple times.
right, but,
That's a concern I have.
okay.
Mr. Chairman, members of the meeting, I've got to run across the street, so please forgive me for leaving early. I did all I could to get here to stay as long as I could, but I can't be late for this one across the street. So, but thank you, and it's been very, very informative and great descriptions and helping me get a better understanding. So thank you very
Okay.
much.
Thank you,
Yeah,
Commissioner.
you.
So, Mr. Chairman, we're going to have another meeting soon for us to go over any concerns that we have now and fill in the gaps on this bill.
Yeah, my thought was next Thursday.
Oh, yeah, 9.5.
Anyone interested?
I'd love to. Does your wife cook well?
We're on video.
Will lunch be served? Sure. Yeah, maybe some turkey soup. But no, in all seriousness, what I'd like to do, Representative Green, is I think it's imperative that we do a couple things. I'd like to give you guys time to, I know the model isn't all that sophisticated. Take a look at that. Take a look at the bill. Take a look at the PowerPoint. I can commit to you that by Wednesday, I'll get out a modified PowerPoint based on literally a myriad of different notes that I've taken today. Get out that information so that everyone can consume that as much as possible. Work hopefully with a data scientist so that we can get real data plugged in and then move that out. We're going to ask the speaker to extend our deadline out into later into December. My goal in a perfect world, but Jackie will get with you guys, is to meet the first week of December, the latter part of it. I know that's the week right after Thanksgiving.
Fridays.
Not Fridays, Thursday then. Okay, Thursday. We'll meet Thursday and just be able to get as many, because I'd like to meet then, so then that way if we do have one more time we have to meet, we can do it before Christmas. But if we can knock it all out that Thursday or that Wednesday, depending on when you guys are available, I'll have Jackie reach out to you.
Sounds good.
Is that okay?
Yeah.
All right. Before we start heading towards adjournment, anyone have any comments?
Maybe just a question. There we go, thanks. So, so data scientist, 2 weeks.
We
We
need to extend into next year, I'm afraid. I don't know, because we want to
Okay.
have the data scientists. I'm
Yeah.
concerned we won't have enough data that's
Okay.
going to analyze. I know we want to get something done, but I'm concerned.
Yeah.
How about then let's go
And
to
I-
the third week.
And I still like, maybe it's the idea of just making as much progress as we can, although deadlines work. So I don't want to create an undeadline and let's just, keep on spinning. But I do think setting the expectation of one more meeting in 2 weeks, and then we're going to be ready to put actual, finalized language to a bill before the holiday seems really aggressive. But again, this is my first study committee, so I'll defer to the chairman and the rest of the team around how to do that.
Of course, I'm a little slow, some of my same concerns, but rest assured, during the 40 days, it'll be changed plenty of times. No, I'm not being funny. I'm talking about it'll
understand.
be so scrutinized. The data scientist is the only problem I see, or whatever what you called him or her.
So I think it's a great point that's being made. Why don't we shoot for then the week of the 16th? I know I don't want to get too close to Christmas though, so it might be the earlier part of that week as opposed to the latter part of the week of the 16th. If we can get someone on board to help us with some modeling, that would be helpful. I don't want to make blind decisions. No one is suggesting I want to run this through. And if we can't get the information, then we'll have to call an audible. To Dane's point though, I'm not a big fan of, interminable deadlines, and I would like to get something onto paper if possible for us to react to, because there's going to be a lot of different people wanting to react to this bill. And I'd like to get the reactions, to your point, Representative Tarbin, as quickly as possible, so that if we're going to get a complete meltdown, I'd like to get the meltdown earlier than later. Okay? Any other? Oh, please, Dane.
Maybe one more question, and maybe I just didn't read the Hamilton report as closely as others did, but I don't recall things like a penalty in the Hamilton. Was it in there? Okay, good.
That's me.
So here's a question: is there any value? Because I think the guys that are at Northwestern now, I think they're interested enough to potentially help.
Yes.
Now, I don't think from the data science, I bet you that's a
No.
bridge too far. But on these things like and I called it cost of living, but that's the wrong thing. But this idea that the indigent care keeps on going up, so that plus a penalty, maybe the inpatient versus outpatient, some of these questions that we talked about. I wonder if the gentleman from Northwestern would maybe even act as another resource to the committee for some of these theoretical, I'll call them theoretical questions, baseline questions, maybe in parallel with the data scientist work around the model.
I think that's a great point. We've been exchanging emails. I consider them a resource. I consider them, call it de facto part of the committee, even though they're not. So they have been enthusiastic in their willingness to help us. I'm sure there's not many times in life where a PhD writes a white paper and then suddenly possibly comes to life. You know what I mean? So it's pretty exciting, even for Kellogg, which is obviously a great business school. So why don't I reach out to them Monday and see if we can start getting some of their brain power around at least the thought process, and maybe get some of their thoughts. And if it's something that they'd be willing to do, and they have said they would, especially if we did it earlier the week of the 16th, not so close to Christmas when plane fares become ridiculous. My hunch is they would even fly in and have a conversation with us if we could keep the expense, within reason.
I bet they would.
Yeah.
Thank you.
Yeah. So I'll take that upon myself. Okay. And I'll speak to those guys.
Thank you.
Okay. Teresa, you have anything? Everyone else is good. All I can say is thank you. This is exactly what I wanted today to be. I wanted it to be a working session. I apologize. It was this awkward creating a committee room into, I would have rather just been around a table. But I think it did work. Thank you for the collegial atmosphere. It was definitely one of let's find a solution as opposed to let's find a nuclear bomb to explode. So that's the type of attitude that I truly, truly appreciate. I am indebted to all of you, and I apologize that I put you into Friday afternoon rush hour traffic. And with that, we are adjourned.